Yes, so Sandeep,
Yeah.
I can't get through to him on the phone. So if we don't have his recorded talk, we will have to go ahead with Dr. Kiran Kush's recorded talk and keep the others in their normal order because she won't be present for the Q&A.
Excuse me, sir. Shall we start?
Could you tell me if you have got Dr. Atawal's talk, or is he going to be present? Has he intimated? I know he won't be there for the panel discussion.
Sure, sir. 1 second. Dr. Attawar. Yes, sir. The recording has come.
It has come. Great. So we can stick to the thing. Could I just ask you to be really, really brief? You don't have to go through the program and talk about who's there. We'll take it to save time.
So it's 3:30 now. You can start Sandeep's talk, I think. I think Kapadia is the chair.
Yes. So what I'll do is I will just briefly say what it is. I've got that sort of 5 minutes there, but I won't take 5 minutes. I'll just let me know when you're fully on air.
Sir, I'll start this talk.
Yes, go ahead.
Yeah, welcome, gentlemen. Today's topic is forward onwards, disruptive evolution in thoracic transplantation. The first topic is on pandemic preparedness, Q&A, and the speaker is Dr. S. Attawar. He's the chair and director of thoracic organ transplants and assist devices at Parkway Global Hospitals, and is one of India's foremost cardiothoracic surgeons, and also an active member in international cardiothoracic forums. The chairpersons are Dr. N. Kapadia and Dr. Ajit Kumar. Dr. Ajit Kumar is HOD Cardiology of SIMST, Trivandrum. Dr. N. Kapadia is the Director of Heart and Lung Transplant Service in Kokilaben Dhirubhai Ambani Institute and has 36 years of service in cardiac sciences and is one of the prominent surgeons in the field. Over to you, sirs.
Great. Well, welcome everybody for the second day of this heart-lung sessions. Today is really about what's going to be disruptive in our practice. And we're going to start off with Sandeep's talk on how really we've had to adapt for pandemic preparedness. And the reason it sits within this disruptive and future sort of program is because I think we're going to have to be continuously ready for such challenges that will occur. And I don't think we've seen the last of the pandemics or some major other natural force that really puts stress on our systems and affects us in a way we have to change the way we view and actually deliver our practice. So over to Sandeep.
Yeah, so I think it will be recorded session, but after the session is over, we'll have ample of time to discuss on the questions. Can we have the presentation now?
I'm Sandeep Attawar, and I thank the Society for this opportunity and the invitation to speak today on pandemic preparedness as part of this elite panel. Transplantation has become an established treatment for end-stage organ disease and is a highly regulated field. There are several threats to transplantation, but the one particularly important threat is that of emerging infectious disease. Since the 1980s, there have been several emerging viral diseases, including HIV in the late 80s and early 90s, the West Nile virus, the pandemic influenza H1N1, Zika, Ebola, and now pandemic COVID-19 caused by the SARS-CoV-2 virus. For each of these threats, transplant programs have responded in a coordinated fashion to be able to mitigate risk for recipients by assessing not just the risk of donor transmission, assessing the severity of disease in the recipient, and recognizing the potential for transmission to healthcare workers. This knowledge has been used to generate algorithms for donor screening, avoiding organs from potentially infected donors, and better recipient management. Many of these emerging viruses have been manageable, sometimes only limited to certain geographic areas, and transplantation and donation has been able to continue to adapt to provide this life-saving therapy to patients in a safe and effective manner. But this current pandemic is unique and it's unprecedented in modern times. It has crossed borders, infected more than 110 million persons worldwide, and undoubtedly so many more undiagnosed cases are yet to be diagnosed. Unofficially, more than 2.4 million deaths have been recorded, and it's difficult to contain, partly because of the contagious nature of the virus and its ability to mutate. It's mild affliction in the majority of individuals, and by its very nature of being a very pervasive and an insidious pathogen. The emergence of COVID-19 has impacted transplantation worldwide and has become the bane of both physicians and patients with end-stage thoracic organ disease. So what this virus has done is it has continued to demonstrate its ability to find people who are not vaccinated. So when we begin, it's important to have some background. As I did mention earlier, we know that this pandemic has upended and irrevocably changed many aspects of healthcare delivery, of which transplantation has been affected the most, largely since every single resource that transplantation depends upon has been diverted to the care of COVID-19 patients. We've had severe constraints in time and the mode of transport of organs after their retrieval, which has created a great deal of impact on the field. Lesser organs were donated, lesser blood products are available, and while staffing and space were at their least available, this activity demanded nothing less than standard outcomes every single time that increased the constraints and the pressures on teams that were actively transplanting. In this presentation, we will discuss some of the strategies to mitigate risk for patients and healthcare workers. We now already know that COVID-19 is not just a respiratory virus. It has a multi-system involvement as far as the body is concerned, and it is a fertile ground for many other infections to settle on a fungating lung. We know that with advanced care for many of these patients, like mechanical ventilation, long-term ICU stay, and sometimes even the use of extracorporeal support, many other organ systems are irrevocably damaged as far as COVID-19 is concerned and the attendant effects of advanced life support. We also know that the brain, the kidney, and the heart are equally involved in this disease process. We are also aware that it is inherently a complex hematological problem. COVID-19 is known to cause in situ thrombosis in many organs, especially the lung. It also has led to a lot of hematological disturbances leading to bleeding dyscrasia, strokes, so on and so forth. There have been many anticoagulation protocols that have been initiated to take care of these patients. Unfortunately, we don't have a final answer to any one of them. And so that only exemplifies the challenges that most of us as physicians face. So to round it up, we have innumerable challenges. And we also know that repeated testing of recipients who turn up for transplant is not an insurance as far as we're concerned. This virus has a period of clinical quiescence, which can easily evade every test, even those that are even as much as close to perfect. Most of us as clinicians are left without guidance on management choices. We are left balancing resource constraints. We are concerned about patient safety. And we also know that a patient who's dying without an organ has a logistical nightmare to circumvent or overcome when a donor organ is available from a distant location. At the same time, if an organ is available, there comes an ethical dilemma of whether to transplant in these times, especially for patients who are more stable. So making this decision of a life-saving transplant sometimes is a decision that is something that we all wrestle with as transplant physicians. We also know that denying a standard waitlisted transplant recipient the chance of a transplant when he gets one, when he's in best shape, may have many long-term repercussions. Because of worsening disease, he could become a worse candidate than he currently is, leading to a worse outcome in the long term. And there's no knowing when the next available organ of an adequate quality would be available. So when we're looking at problems, we also need to figure out solutions for most of them. So when you're looking at the problems, we should look at how we organizationally respond to the pandemic. We look at screening and exposure of staff and how to circumvent these problems. We're looking at challenges with donor screening, challenges with the timing and the logistics of transplantation. We have to wrestle this question about the benefit of transplant. We have to maintain the morale of the team, and we have to end up protecting the team, both during the retrieval and during the process itself. So when we look at the organizational response, we must understand that the response to the pandemic requires a team-based approach that requires multiple competencies. We need a strong pre-existing administrative communicative structure that is anchored by weekly meetings during which the physician leadership and administrators discuss clearly the clinical issues, the research that's available, and the operational issues that we face. The group culture has to be one of open discussion and shared decision-making, leading to a high level of trust between members. The existing organizational structure is reformulated at times to be able to develop a crisis team that gathers not just unit leaders, nursing leaders, many other clinicians and administrators. The guiding principles of this crisis team includes excellence in patient care, staff safety, data-driven decision-making, and an adaptive structure with regular communication. To be able to make these informed decisions, it's important that physicians that round up during clinical services must be made part of this. They should be asked to attend. And then it's the responsibility of the leadership team to accumulate, dissect, analyze, and then create information in a streamlined fashion to be communicated by various communicative mechanisms, including frequent emails and periodic video calls, where some of these questions can also be answered as and when they are raised. So this is a lot of work. When you're looking at screening, I think we all know how screening happens now, other than the extensive screening of the staff, which allows us to increase their safety levels. It prevents a breakdown or a vicious cycle of in-hospital transmission. But however, the challenges are it increases costs, and you may lose many staff as they get quarantined when you screen or you test extensively. There are travel restrictions, and these are largely brought on by the fact that we would like to reduce the extent of the contagion caused by team travel. The disadvantage is that we need to develop novel new systems of organ sharing. When you're looking at some of the issues that you need with an outstation organ, you might need a local retrieval team. The advantage is it allows your team not to travel, and it also allows you to leverage the challenges that are brought on by reduced flight availability. But the disadvantage is that you have literally no time or a short time to upskill a local retrieval team. The problem is if they're not trained well enough, the quality of the graft can be suboptimal. So when you're looking at guidelines or algorithms for how you would screen a recipient, the one that's in the hospital is fairly simple and straightforward. You just need to do a swab and probably a repeat CT scan. You could probably then decide on how you would proceed from there on. The challenge is especially for those patients who are at home. So a proper history taking for upper respiratory symptoms or contact with somebody who has been COVID positive in the preceding 2 weeks is important. And based on that, you could decide that if the patient has no symptoms, no contact, you could probably proceed if both the CT scan and the rapid test are negative. However, if that is not the situation, then probably excessive care and caution is exercised. When you're looking at donor screening, transmission of SARS-CoV-2 from donor to recipient has not yet been reported, though we have had anecdotal reports of such. The risk of viral transmission has to be balanced against the risk of not using the organ. And it's very important to realize that any donor with a history suggestive of SARS-CoV has to be avoided. All donors have to be tested wherever possible by a PCR test, and probably 2 tests, especially for a lung transplant, are important using a deep respiratory BAL sample. The potential tools are things that we already are aware of. The chest CT scan is something that is mandatory almost in a thoracic organ transplant. And regardless of donor screening, a discussion of risk benefit is extremely important for patients and their families in case you're transplanting during an ongoing pandemic. It's important to consider the protection of the retrieval team. And as I did mention earlier, both organ retrieval and transplant are aerosol generating procedures. So we try to focus on local organs, minimize the number of people who would travel. Outstation organs, as I mentioned earlier, would be by a local team if possible. Team members should follow all pandemic travel guidelines. They should have a screening questionnaire before and after. They have to probably isolate themselves after a travel. And we have to be sure that they are adequately compensated for all their effort. So these are things that add on to costs of transplantation. And when we're looking at the timing and the logistics, we're looking at various issues like the screening of waitlisted patients, the recipient testing at the time of transplant, a backup recipient in the hospital, the use of organ care systems or machine perfusion in many of these cases. And lastly, how do you stay in touch with patients in the outpatient who are awaiting a transplant? And the use of telemedicine in this has amplified a great deal. So there are advantages and disadvantages to most of them, but one of the main challenges happen with backup recipients in the hospital. So many a times, if your priority number one recipient turns out to be positive, it only vitiates the complex logistics. It increases the anxiety and frustration for backup recipients because they do not know the answer to whether they would have a transplant on that day. It increases the logistics and costs. And sometimes when the first recipient is positive, the challenges of the OPO reallocating the organ to someone else is an added headache for most of the transplant teams. Not just causes unnecessary delays, causes a great deal of stress, and only adds to the anxiety and the stress that the team undergoes when they perform a difficult operation in a very short period of time. So when you're looking at the benefits of transplant, I think it's important for us to remember that hospitals have to revisit their local policies on the availability of organs, the access to transplant based on their resources. And we have to make a realistic allocation between COVID and non-COVID cases. The disadvantage of all of this being the stretch of a healthcare resource to almost break point. And all of us have limited resources, as we all understand. However privileged or however well, I would say, well-staffed we are. And besides, over and above all of this comes the question of privileging utility, which means deciding on those recipients with better outcomes. Should we privilege them? It leads to lesser resource consumption, faster turnaround, lesser transfusions. But the challenge is we miss the sickest and we increase waitlist attrition. But if you privilege urgency, you prioritize the patient with the highest need, you definitely are treating the sickest, you're ethically doing the right thing. However, you're utilizing more resources to the effect, leading to greater mortality, higher morbidity, and many times when you have a negative outcome, you lead to a degradation in the team's morale, and you have an uncertain cascade effect on the bottom of the elective wait list. When you protect the team during transplantation, it's important to understand that adequate PPE is important, which has been standard. We utilize N95 masks or equivalent for most of the team members, both during the retrieval and the transplant procedure. Face shields are recommended. Minimizing personnel in the OR is important. It's vital to minimize the use of diathermy, use bipolar coagulation if possible. Energy coagulators are necessary because it prevents aerosolization. Donor bronchoscopies after a lung transplant, if performed in the operating room, are performed with adequate precaution. And if possible, the OR should be a negative pressured OR. And likewise, the ICUs should be negative pressured as far as possible. And these are all position paper directed guidelines from the Society for Organ Transplantation during the SARS-CoV epidemic. Lastly, when you're looking at the phases of the epidemic, it's important for us to understand how we modulate our activity depending upon the epidemic phase. This is a great recommendation paper that came out from the Journal of Heart and Lung Transplantation from the COVID task force. So what it says is that during the anticipation phase, the number of patients with COVID-19 admitted are low, but they are expected to increase. There are sufficient resources at the hospital, but many of them are preemptively reduced simply because we are awaiting a burst. Many travel restrictions and social distancing within the community are introduced, which affects the scheduled care of standard patients. The risks from this, from a healthcare perspective, include an underutilization of resources and incomplete preparation for the upcoming stage. When we move on to the phase of the active phase of the pandemic, an increasing number of patients with COVID-19 are being hospitalized. The healthcare system is functional. It has adequate hospital capacity. It has adequate medication and staffing. There is no scarcity, but resources are gradually reallocated in the fear that things may only just tip. Organ donation significantly declines. However, the risk continues to be the fact that hospitals intentionally underutilize available resources, and there is always a fear of transmission of infection to healthcare workers. When we move to the stage where we are all overwhelmed in the stage of any pandemic, and as the COVID-19 pandemic has shown us, the number of patients with COVID-19 in the hospital are a large proportion, mainly the critically ill ones. So rationing of medical resources such as critical care capacity, staff or protective equipment is absolutely mandatory and necessary. Organ donation stops. The number of healthcare workers absent due to infection, quarantine or burnout is substantial. And the risks now become that there's an inadequate care for infected patients and an inefficient allocation of resources for patients with COVID-19 and other patients with other illnesses. There's very high morbidity and mortality in both groups, and there is a substantial risk of infection and exhaustion and psychological trauma to healthcare workers. We then move on to a stage which is called the stage of recovery, where the number of admissions is gradually reducing, but bursts or secondary waves keep happening. Normal activity can resume slowly. Resource availability is still unpredictable, largely because of fears. Augmented measures to prevent disease transmission are still required, and the risks to the healthcare system include the insufficient or inefficient use of available resources and sometimes an increasing level of infections simply because of premature loosening of infection control practices. From here, we move to the stage where a new normal has been set, and this happens after the pandemic. Many hospital and outpatient clinic routines have changed. There's an episodic burst of local epidemics, resulting when the disease becomes endemic, resulting in a periodic need to reduce elective procedures. Overall, the hospital resource availability may be permanently changed as a result of this pandemic, and the lessons learned during this may alter the healthcare workflow measurably and sometimes permanently for the worse. In response to every phase, it's important that this paper considers how the various stages of the pandemic might look at a healthcare institution perspective, weighing the practical and ethical factors that characterize thoracic organ transplant and the service of patients with end-stage heart failure, utilizing mechanical circulatory support to treat some of them. So while we round up, I'd like to conclude that this pandemic has been an unprecedented, life-changing crisis, which has caused wide-scale disruption. Our health centers and our health systems are inherently or culturally patient-centric. This pandemic has forced us to shift our focus from individuals to communities in the larger interest of the survival of the human race. This shift has been very abrupt, it's been jarring, and it's been one that has been very difficult to comprehend and adjust to. Transplantation is the apex of all medicine, one of the greatest achievements of human history that needs teamwork and collaboration of a sublime level. We were forced to, and we will continue to be challenged in this noble profession in these times of radical change. We thus need to shapeshift, we need to morph, and we need to evolve continually. And in ending, I would like to say that it's clear that there's a lot of human wood out there for this coronavirus forest fire to burn. Thank you.
Thank you, Dr.
That's
Rao,
great.
for that.
I don't know if he's available. Well, he said he wasn't, so I'm not sure he's there. So I think what we might do is we've got sort of 7 minutes. We could probably, are there any discussions there? Any questions that we could do in his absence?
Okay, Kumud, I have a very important question to discuss. You know, whenever we have donors who have potentially recovered from COVID-19 infection with minimum lung involvement, heart is good, and they end up into either road traffic accidents or they have intracranial hemorrhage. And there is a lot of hesitation many times from the hospitals where the donor is, even not to inform to the local authorities that they have the branded donor who has recovered 3 or 4 weeks ago. So what is our thought? I mean, we need to educate the people and spread the awareness that, well, if COVID negative, I mean, after 2 weeks or 3 weeks, mostly we say 28 days, but what do you think? I mean, how to spread the awareness? Because many donors have been wasted in this way.
Correct. And I think given that we're going to see an increasing, this is now going to be a subclinical problem, one of being COVID positive, particularly in doubly vaccinated patients who have got away with either subclinical or very little symptomatic disease. And we will see them forming greater portions of the donors that you mentioned. So we really need to think about how we produce guidelines to advise and inform the regulatory authorities so that we don't lose out on very good organs, or that which can be very good organs. I would suggest that we currently stick to the evidence base, which is very little, but at least on that, there's some guidelines that have been internationally respected. We should respect those timelines. If anything, add an extra few days or 2 or a week if we need to make sure we're doing our best to make it recipient protective. That's easier for authorities to then accept, as opposed to just going straight with the bare minimum of safeguards. And that would mean that, somebody who's 3 weeks is plenty for somebody who's not been symptomatic and not been admitted to hospital. Remember, the 4 weeks is really for somebody who's almost been in ICU. So we can define those timelines. It may be something worthwhile to do from the INSHLT group, or we could do it together to actually produce that and form a basis so that we don't, as you say, lose out on these donors. I think it's a really very, very valuable point. It's going to be with us for a while, and we will face it increasingly. And this particular coronavirus, I'm sure, will just become part and parcel in the flu season, along with the other coronaviruses that have been around for many years.
Yeah, thank you. So any other question from our panelists or delegates who are attending, or any comments?
Well, I think one of the major things that we've seen in this occasion from the surgical perspective, not least from an overall hospital one, is the need to so rapidly shift what we do. It's almost on a war footing. This is like a major, major disaster where you have to make infrastructural changes. You're not just utilizing to full your infrastructure. You have to change that infrastructure to make sure it's safe for staff, other patients, and for the patient himself herself to receive appropriate therapy. And that means that our ICUs, our ECMO ICUs, those facilities, we really have to rethink when we design the hospital structures. Is that, okay, if we get a pandemic, how will our infrastructure work, and how best will we be able to deliver the maximum that can out of the available human resource and the infrastructure that we have? And those questions normally don't affect us. We base those on expected workload of routine volume of work. And so when you run hospital institutions and healthcare facilities to the brim, this is what happens. We can't cope. And hence it's always best to run it around the 80 odd %, because you have capacity for surges that can occur. 80% occupancy wouldn't help even with this, but it will give you cushion. It will give you some time to upskill and up infrastructure.
Yeah, second thing is whenever healthcare workers are sick in any hospital, like nurses and doctors, technicians, they are told to stay at home and they join back within 14 days. And we have never seen that anybody spread the infection among other colleagues. So what do you think about that? So 2 weeks is safe after the recovery of the mild or moderate symptoms? And why the donors who have recovered from the minor symptom, they should not be included after 2 weeks or 3 weeks?
So firstly, there have been a significant number of in-hospital cross-infections amongst colleagues. Absolutely, we've seen that in transplant teams as well. So, but as long as your symptoms have been mild and you've isolated for the 2 weeks, it should be sufficient. And actually doing an RT-PCR test at that point does not necessarily mean that it's somewhat meaningless because of the high rates of false positives that you can get. Now, just go through that last bit about the donors you were saying. Donors?
No, I'm just saying that, many times the donors maybe just 2 weeks down the line had mild symptom, met with an RTA.
Yeah.
You cannot hold the donor for, the timeline of 28 days as per guideline.
Well, I think that is because of trying to be absolutely. See, I think we need always to be recipient protective. There have not been sufficient transplants. Well, if you look at the outcomes of transplants of COVID patients from, they're not that great. So why would you want to, what we want to do is to see improvement, whether it's from donor or from the recipient, that the COVID in any aspect leading to a transplant improves. And we need to do that by being very, very cautious. So I wouldn't tinker with the timeline on the donor. I would just stick to the established guidelines, which I think will allow us to lower those limitations. It is 4 o'clock. I think we should move on with the next talk. Please, chairs, go ahead and present the next speaker.
So the next topic is on donor organs, machine perfusion, and transportation. The speaker is Dr. Jay Schroeder, interventional cardiologist and specializes in diagnosis and treatment of heart and vascular disease. He's a member of American College of Cardiology, American Heart Association, and American College of Physicians. And the chairpersons are Dr. Suresh Rao KG, who is the co-director, Institute of Heart and Transplantation and Mechanical Circulatory Support Devices, MGM Healthcare, Chennai, and served as a professor of cardiac anesthesia at Sri Ramachandra University, and is presently the co-director of Heart and Lung Transplantation Program at MGM Healthcare. The next chairperson is Dr. Sarvesh Pal Singh, who is a faculty at All India Institute of Medical Sciences, New Delhi, and the current secretary of the Indian Society of Heart and Lung Transplantation. He has published several research papers on heart transplant, and his current research is focused on preservation of donor heart. Over to you, sir.
Thank you so much for having me. I just want to make sure, can you all hear me?
Yes, we can.
Excellent.
Thank you
So
for being here.
I want to thank you all for having me. It is my pleasure. Let me just get my slides going. Can you see that?
Not yet.
Okay, hold on. Let me try again. Sorry.
Yep, we got
Okay,
it.
good. Perfect. Okay. Well, again, thank you so much for having me. If at any point you have Kumud there, so you have an expert, but if you have any questions or comments about DCD heart transplant, please feel free to reach out and contact me 24/7. This is my email address and my phone number in the United States. Just a little bit about us. So, I'm at Duke University Medical Center. I'm actually a cardiothoracic surgeon, not a cardiologist, but you see the growth of our program has been significant over the years. And, we had a lull in sort of 2014, 2015, when we had a really high rate of primary graft dysfunction. But since that time, we've steadily grown. And I will say that that even during the pandemic, we've had the largest number of transplants per year, so 104. And to put that into perspective, we're in Durham, North Carolina, which is a small place. We're not in New York City or Los Angeles or Atlanta or any of those large cities. And so the way we've done this is by maximizing potential for both donors and recipients and using technology. And I'm going to talk a little bit about DCD heart transplantation. Obviously the problem with heart transplantation is a donor limited one. Only 1/3 of the hearts that are offered are actually used for heart transplant too. And so, in the United States, the number of transplants has gone up, unfortunately due to the opiate epidemic in the United States. But still, if you think about it, there are probably 200,000 or 300,000 people with end-stage heart failure who theoretically could get a heart transplant. So, 3,500 transplants is really a paltry number. So what is DCD, donation after circulatory death? So as opposed to people who are medically, legally, ethically brain dead, DCD donors have had a devastating neurologic injury and are brain injured but not brain dead, but still wish to donate their organs. Currently, we only use Maastricht classification 3 donors, anticipated circulatory arrest, although there are some centers around the world who are doing things differently. This is where we're at in terms of the United States. So, why is this important? Well, we looked at the UNOS results in retrospectively and looked, and actually went through and estimated that the donor pool would be increased by at least 30% if we were able to use suitable DCD heart donors. And I'll be honest with you, I think that actually that is an underestimate because we're actually getting more offers than expected. Of note, the first heart transplantation done by Christopher Barnard was actually a DCD transplant. The donor was a young woman who suffered a devastating neurologic injury in a car accident. The donor and recipient were co-localized, and they withdrew life support. And after a cardiopulmonary arrest and a 5-minute grace period, they put the patient on cardiopulmonary bypass and cooled as a means for organ preservation. So, well, why do we know that this will actually work in this day and age? Well, we know that because our moderator, Dr. Datal, was the first to do it. And I always am amazed by the sort of perseverance and faith in this process that Kumud and his team had. You know, you see this slide is obviously Kumud's, and you see the heart initially instrumented on the TransMedics OCS. And I got to say, if I saw that as the first DCD heart transplant in the modern era, I'm not sure if I would have persevered, but they did. And you see the heart in the recipient on the far right panel, and it looks great. Truly an amazing accomplishment for Kumud and his team. And so we know this works because of other centers too. So St. Vincent's, where Kumud was in Sydney, and Papworth in Cambridge. You know, these are just some of Papworth's results, and you see that their 1-year survival is equivalent. They increase their transplant activity. And this is probably the most important slide of any data that I have, I think. So this shows the 6 centers in the UK that perform heart transplantation. And the black line is their wait list. And you see that all the other centers, their wait list actually is increasing. Even though a couple of them, their heart transplant numbers are going up, their wait list is still increasing at a significant rate, significantly faster than their transplant rate. But if you see Papworth in the lower right corner, you see that their waitlist numbers actually plummeted when they started doing DCD heart transplant. And I'll tell you, that's exactly what we've seen too here at Duke. We've actually had times where we really had nobody on the list that was suitable for transplant, frankly, because we've been transplanting people so much more quickly. We've cut our wait times significantly. Our wait list time is half the national average, and using DCD, it's actually decreased significantly also. So, you know, the traditional recovery, you all know, the patient is declared brain dead, and we inspect the donor heart and cannulate for procurement, and then arrest the heart and recover it, and then transport back on cold static storage. Obviously, the time is clicking. For us here in Durham, North Carolina, that gives us a limited radius of procurement. And so, you know, that really means sort of the eastern side of the United States, if we are going to take into account what we would recommend as a sort of 4-hour ischemic time. When I was a fellow, way back when, I don't know, 15 years ago, I was interested in getting involved with the TransMedics OCS because I always wanted to go to Puerto Rico, which is off the coast of the United States, and because we always got offers from Puerto Rico, but you know, it's a 3.5 to 4 hour flight, so obviously too far for us to go to procure an organ safely with cold static storage. The OCS devices allowed us to change this. We've gone to Puerto Rico 4 times. We've gone as far west as Wyoming, which is pretty far away. The only reason we haven't gone to California and Washington State and farther is because our pilots time out. And so if we flew there, the pilots would time out. We'd have to find another plane to come back. So we have to figure the logistics of that out. But it is definitely feasible. The first OCS heart we did, brain dead OCS, as part of the EXPAND trial, we actually had the heart on the rig for about 9 hours. So again, we can go further and farther. So the US DCD trial, which is now closed actually, and I'm hoping to present the 1-year data at ISHLT in April. was a randomized trial, and you can read the inclusion criteria and exclusion. And so the important thing is that we defined in that trial the warm ischemic time as time from when a mean systolic blood pressure is less than 50 or a saturation of less than 70. And these are all very debatable, and Kumud can probably discuss this too. I mean, we spent hours discussing this and debating, but we wanted to be inclusive. And based on the Sydney data and the Papworth data, which there are some differing opinions from those two groups, who are obviously the world's sort of experts. We wanted to be inclusive and use as many DCD hearts as possible. The inclusion criteria, so primary heart transplant candidates, so no multi-organ transplants, but we have actually done, with compassionate use permission from the FDA, we've actually done a number of multi-organ transplants using DCD organs. And again, exclusion criteria, so they couldn't have had a prior transplant. And obviously we have to be willing to randomize them. So it was a randomized control study, and I only put this up there because to point out the fact that, so it was supposed to be randomized 3-to-1 to DCD possible. Now, if you're in the DCD possible arm, you could still get a standard of care heart transplant. Obviously, you know, we picked the best organ for the patient at the time. So even if you went into the DCD possible arm, you could get a standard of care heart. And so we went 3-to-1 DCD possible because we thought, oh, you know, there's still going to be more standard of care transplants that occur than DCD, and that the exact opposite actually occurred. It turned out that we did so many DCD transplants as part of the trial that we did not have a control arm. And so we had to continue, and we actually changed the randomization so that we would have more people in the standard of care arm to compare the DCD arm to. So it's a fairly standard setup, and Kumud can speak to this. It is, you know, procurements are always an experience. We try and make sure that when we go on these DCD procurements, because many places we go have never done this before in terms of heart procurement, that we are fully self-sufficient. We set up everything ourselves. We don't need a scrub nurse. There are 2 surgeons, myself or one of my partners, Ben Briner, and usually one of our advanced fellows. And we have everything, and we can do the whole procedure with literally no one's help other than somebody to run the OCS. The procurement, you know, the withdrawal of support occurs, they administer heparin. We start the sort of warm ischemic time, as I said before, with a SAT less than 70 or systolic blood pressure less than 50. And then, you know, as part of the trial, we will wait up to 30 minutes now. One of the other co-investigators in the study called me one day and said, hey, we lost track of time, and our warm ischemic time was 41 minutes. And I said, well, how old was the donor? They said, 22. I said, well, how's the heart doing? He said, fantastic. And so, you know, again, it points out that we need to continue to do significant more amounts of research on this topic, because I think that having a strict guideline, I think, you know, warm ischemic time of 30 minutes may be too long for the 48-year-old donor, but for the 21-year-old donor, it may be just fine. You can factor other things in like PEA, et cetera. But again, I think we need to do more research on DCD donation in terms of heart transplantation. So the one difference with using the Transmedics OCS is that to run the machine, we actually remove blood from the donor and use it as part of the perfusate. This is sort of the critical part of the procurement because it causes a lot of consternation amongst our liver transplant colleagues. And I don't begrudge them that, you know, with the increasing warm ischemic time, the risk of ischemic cholangiopathy, which is, you know, not immediately evident, can present itself 6 months, a year later, is really significant. So, you know, we used to do this by passive drainage, open the right, you know, you do sternotomy, open the pericardium, put a cannula in the right atrium and passively drain blood, which works sometimes because, you know, usually the donors, you know, with no blood flow, the CVP, the central venous pressure is, you know, sometimes 30 or even higher. And so the blood will passively drain out, but we definitely have had some issues. So the one thing that we have done to change this is actually using a self-salvage canister, and we hook our 2 suctions from the field up to this self-salvage canister and actively remove the blood. And since we started doing this, no liver team has ever had to actually really wait for us to actually get the blood off. We then take that cell salvage canister and then filter the blood into the OCS machine. This is a picture of the connector that we use. And then, once the blood is drawn, I always tell the liver teams especially, this is just a normal procurement for us. We can take our time. There's really no rush. You want to get obviously time is of an essence, but we don't need to do anything crazy. Obviously, we then just flush the heart with del nido cardioplegia, remove the heart in the standard fashion, instrument it, and put it on the Transmedics OCS. Here you see a heart on, and so this is essentially a miniaturized cardiopulmonary bypass pump. It perfuses blood into the aorta at the top, which has a vent. There's a PA cannula to measure coronary flow. You have to assume that all the blood, if there's no PFO, all the blood that's coming out of the pulmonary arteries is blood that has gone through the coronary circulation and is coming through the criteria donors and understand what we can measure on the heart, and importantly also what we can do in terms of modulating the heart, whether it be biologic agents, medications, gene transfection, et cetera, to make donor hearts more suitable for successful transplantation. So on December 1st of 2019, we did the first DCD heart transplant in North America. You see a picture of myself and my senior partner, Dr. Milano. So, in brief, this is our experience. So we evaluated 93 hearts for transplantation. There were 23 DCD hearts that were not implanted. So 18 of those donors did not expire. Another area of research that we need to really try and figure out is who is going to pass away and who is not. So 18 did not pass away. So I call those true dry runs. So 20% dry run. And we had 2 donors that passed away in the allotted warm ischemic time, but we had sternal saw issues. One time the saw blade broke and they didn't have another one. And they dropped the Lipsky knife on the floor when they tried to pass it to me. And so I, in terms of, I'm sure there was another alternative to try and make this happen. But, again, for us, we don't want the liver teams in the United States to freak out, frankly. And so I just said, okay, well, we'll get another offer, and that's okay. But we've done 73 DCD heart transplants. That date is wrong, but 73 DCD heart transplants to date. And actually, I don't think that's even accurate because I think I did 1 this week. We've done 5 transplants at Duke this week, and I think 1 was DCD. Anyway, 34 is part of the original trial, and we've done 7 compassionate use exceptions. So 4 heart kidney transplants and 3 redo heart transplants with DCD organs. Unfortunately, I'm not allowed to share the trial data. The 6-month data looks fantastic. I'll tell you that. That's all I'll say about the actual trial. But if you look at our first 30 or so DCD donors, the important things, the warm ischemic times are short. We've been very smart about which donors that we actually go and evaluate. It is time consuming and costly to do this. We have a team of 2 surgeons, a perfusionist for the study. We had a research coordinator, and the Transmedics OCS is very expensive. So I think that's great. Our warm ischemic time was short. Initially, in our initial experience, we were very conservative and had a 25% use of mechanical circulatory support after heart transplantation. We knew that this probably was going to happen looking at the St. Vincent's data. Most importantly, the average donor age for our first 30 DCD heart transplants was 26. And as I tell all the possible recipients I see, is I say, it really doesn't matter how you get it. You want a 26-year-old heart. Our perfusion time fairly average at 279 minutes. So, looking at our first 34, these are the first 34 that were in the trial. So 100% 30-day survival, 94% 6-month survival, and we had no cardiac graft deaths, and we've had none of the 70-odd DCD heart transplants. These were mainly infections that occurred. Again, I said there was sort of a 20% use of ECMO in the initial population, but we've gotten much more comfortable with how the DCD heart wakes up. It's different than a standard of care brain dead donor. In the majority of these cases, these hearts will come off ECMO or RVAD or whatever within 24 hours. The overwhelming majority, honestly. And I actually have had a couple that I've taken off ECMO in 12 hours. I think they just have to recover from the significant events that have occurred. And now our rate is 5% or less over the last 30 or so transplants. Essentially, normal RV and LV function has been observed in all recipients. We actually are doing cardiac MRIs on these patients and are going to compare them to standard of care transplants. And there's really no, at our institution, there's no difference in the rates of rejection at this point. I would be remiss if I didn't mention normothermic regional perfusion. We do not do normothermic regional perfusion, and it's really a legal issue for our institution. But there are a couple centers that have been doing normothermic regional perfusion. So this is where the donor withdrawal support occurs, the donor passes away. The recipient is then put on central ECMO or cardiopulmonary bypass. Before that's instituted, the head vessels are all occluded to prevent reperfusion of the brain. Then the procurement can essentially occur like normal. After some period of time, the heart is allowed to slowly work more. It's taken off ECMO or bypass, and then the procurement is a normal one. So, I think that there's going to be a lot of hopefully data coming out in the coming years about normothermic regional perfusion in the United States. There are a couple centers, again, Vanderbilt in Nashville, University of San Diego, that are doing more of this. It's much less expensive, which I think is important in terms of overall healthcare costs. This is a picture of the Vanderbilt setup. They basically have an ECMO circuit with a reservoir. You can imagine that as, if you do an operation on somebody with no blood flow, there's no bleeding. But if you reinstitute blood flow, there's a significant amount of bleeding. So you need to have a reservoir. They published their initial experience and their results were quite good. I think the important thing will be to compare rates of essentially primary graft dysfunction when we compare the NRP to using the Transmedics OCS or direct procurement and perfusion. With that, I will end. I hope that was helpful. And if we have time, I'd be happy to answer any questions.
Jacob, thank you. That was an absolutely fantastic presentation and bring us up to date on what's happening in the United States, which I think has really broken that chasm from starting off and suddenly getting so many more units with the help of the FDA-approved trial in the US and these considerable numbers that have now come on board. I'm going to give the floor back to the chairs, and if there's some time, I've certainly got some questions. Go ahead, chairs.
Thank you, Dr. Schroeder. Am I audible?
Yes.
Okay. It was really a nice talk and really an eye-opener for all of us. I have a couple of points to make. You yourself said that your ECMO usage went up once you started using DCD donation in the initial phase, and it has come back down. That explains that everyone has a learning curve between. But do you think the infection incidence which has gone up while using DCD heart, is it related to your usage of extracorporeal circulation? I mean, that you're keeping the heart perfused for so long?
No, sorry. Did you say infection rate?
Yeah, you mentioned that the infection rate went up by 20%.
Yeah, no, so the infection rate is no different. The infection rate was, we had an infection rate before, so we actually do not have an increased rate of infection. We've looked at this. You know, we've had some interesting, you know, just like all transplant units, we've had some interesting, strange outbreaks in the heart and lung transplant, and so we've done a very deep dive on our data, and actually the use of the OCS has never been shown to, at our institution, to have an increased rate of infection.
And
you would
how
think
does
it
the
would.
cost differ? And how does the cost differ compared to a DBD donor? When you use a DCD donor, how much increase is there in the cost of the transplant per se? And is it covered by insurance?
Well, yeah, that's a complex question, but a great one, because you know the disposables, the disposables are $60,000 US. So every time you use this, it's $60,000, which is insane, of course. And you know, it is FDA. It's now FDA approved for extended criteria brain dead donors. Okay, but not for DCD. It will be approved. The insurance companies are balking to pay for that. That indication. You know, the Medicare will end up paying for it. They will say, yes, we're going to pay for this. And then the private payers will most likely pay for it. Now, you know, we have basically, through creative accounting, I probably shouldn't say this, but we've basically done, what we've done is increased our procurement costs for all transplants. And we are probably on some level losing money somewhere. I'll be honest with you. I don't honestly know. And I don't really, as long as the institution doesn't say that we're losing a bunch of money, then I don't really care, frankly, because I'll be honest with you, our transplant numbers have gone up and are going to continue to go up. We hope to do 110 transplants this year. And more importantly, with our decreased wait time, the patients who are waiting for transplant in the hospital get transplanted much more quickly with using this. So, you know, we're actually going to try and do a financial analysis of this to understand the overall cost. Because I'll be honest with you. So if we have a patient in the ICU for 2 weeks before their transplant, I mean, that's probably $5,000 a day.
Not all patients will be in ICU, right?
True. But some of them, you know, so some of them are. So you're absolutely right. Not all of them will, but we will. I bet it will be actually a money-saving endeavor.
Last comment, and I will probably like Dr. Vital also to comment on this.
Just wanted to make sure that you're not excluding any questions from the floor on your.
I have one question.
Yeah, go ahead.
So I have one question to Dr. Schroeder and Jital. I mean, with your large experience, also, you think any importance should be attached to the functional warm ischemic time as a warm ischemic time in terms of outcomes? And
yeah, go ahead, Jacob.
Well, you know, this is a critical issue, honestly, and I think, you know, again, we're going to learn more as we do more. There are some very strong opinions out there, and I would love to hear what Kumud has to say because he is one of the experts. But we will continue to learn about this. What does it really mean? I mean, you know, what does a SAT of 70 mean? Nobody knows. The SAT probe never works. So is it perfusion pressure? When do we really start the warm ischemic time? What is true functional ischemic time? And so it's going to be not only continued scientific research in animal models, but also learning from what we're doing. Kumud, what do you have to say?
Okay, I think it's in the very brief time we have. I think ultimately the functional ischemic time is way more important than the warm ischemic time. But the question is how you're defining the functional ischemic time. And so a definition of saturations, as I say, is completely meaningless peripheral because every donor in that situation, it's all shut down. Some of them have been on NORAD and so on. The saturations is completely meaningless. The 50 millimeters of mercury is from the renal data from historical. And yes, you might get a few blood cells going through the kidney and you can still transplant it. But for the heart, it is absolutely crucial. So we changed our strategy at Sydney to increase the donor utilization by giving a slightly more comfortable functional warm ischemic time metric of a systolic blood pressure of 90 before we started the clock. Because after that, if you start deteriorating, it happens fairly quick. And so that was our clock start. The 30 minutes in the end meant that there were some transplants we were rejecting because we started at the withdrawal time. And so we know, and so that really is very important. You need to know what is your perfusion pressure. And at 50, 60, 70 millimeters systolic pressure in a shutdown circulation, and increasing venous stasis, I would argue that you've got very little perfusion going out into the heart. And you've got a far more swallow. Now, you've got this incredible advantage, I can see, of really young donors. And that's a tremendously young cohort that you've got that we're unlikely to see elsewhere because we don't have the same opioid or gunshot issues that trouble you so much. So we still have so much work to do in trying to get a better handle on this. And, there's so many different ways of preserving the heart. I presume you're just using straightforward Del Nido with no extra conditioning agents, I presume, while, we went with post-conditioning agents. And it's wonderful to see that with just Del Nido, you're getting excellent results. Have you added anything to that?
So as part of the trial, we have not, and just because it was part of the trial, but it opens it up to using data from the other centers who've added things, and I think that's very important. What can we do for these hearts once they're on the OCS to help them? I mean, at some point we could talk about mitochondrial transplantation. We can talk about gene translation. There are all sorts of things we could do. Your points about the warm ischemic time are really important. And, again, this is a debate we could have that could last hours, honestly.
Correct. Well, Jacob, thank you so much for being there in person. We will have these conversations ongoing, and we should continue to with the next talk. Suffice to say that Dcd transplantation.
Yeah, I have just one question to Schroeder. What is the biopsy protocol on this Dcd transplanted heart? Any different biopsy protocol was?
No, exactly the same. Thank you all.
I mean, sorry, with that question, it's always important to remember that if you're doing a new thing, you don't go around changing everything else around. You stick completely to normal protocols, except for the one thing, which is that it's your Dcd heart. If you start changing your other protocols, you will not know if you have a bad outcome, what led to it. So I would not change anything else until you have pretty good evidence. Okay, great. Thank you, Jacob. Talk soon.
Thank you.
And back to the chairs.
Shall we go for the next speaker?
Yes, please go ahead.
Yeah. So our next speaker is Dr. Kiran Khush. She's a professor of medicine in the Cardiovascular Medicine Division, Faculty of Clinical and Translational Research in Heart Transplant at Stanford University. So Dr. Khush has done a lot of work on non-invasive biomarkers in heart transplant and associated with a lot of multiple international trials like DOR study and studies involving Aloe and Aloe, including, I think, the upcoming SHORE study. So welcome, Dr. Kiran.
For acute cellular rejection and not antibody-mediated rejection. So the subsequent study performed. Good afternoon. It's really an honor for me to give this presentation to the Indian Society for Organ Transplantation, and I'm sorry I could not join you live today. The topic of my presentation is monitoring rejection, non-invasive surveillance using liquid biopsies in both heart and lung transplantation. These are my disclosures. The objectives of this lecture are to review the development and use of gene expression profiling for acute rejection monitoring after heart transplantation using a test called the Aloe assay. I will also review the principles of donor-derived cell-free DNA testing, and we'll talk about this assay for acute rejection monitoring, initially using a research-grade assay that we developed at Stanford, and subsequently using a commercially available assay called Aloe Heart, which is currently available in the United States for solid organ transplant monitoring. So to start out with the gene expression profiling assay, the hypothesis behind development of this assay was that gene expression signatures of immune activation and leukocyte trafficking are detectable in the circulating white blood cells or peripheral blood mononuclear cells. And these gene expression changes reflect the state of acute rejection or quiescence of the allograft. And the thought was that a gene expression test could be developed to discriminate the absence of rejection from the presence of moderate or severe rejection after heart transplantation. So this led to the development and performance of the CARGO study, which was one of the largest clinical studies performed in heart transplantation, and this was published back in 2006. In this study, 629 patients were enrolled at 8 heart transplant centers across the United States, and there were almost 5,000 paired blood and biopsy samples drawn for this study. And out of these, 830 biopsies were graded by 3 core pathologists. There were 3 phases involved in this study, called gene discovery, training and diagnostic development, and validation. So the CARGO study was a very iterative study in which the investigators collected a very large library of potential genes involved in the immune response. They started out with thousands of genes and tested blood samples from patients with and without rejection to look at the changes in gene expression of these particular genes. They then identified specific genes that were up or down regulated in the setting of acute rejection and tested these in multiple subsequent cohorts of samples until they narrowed down the genes to 11 that were reliably differentially expressed in the setting of acute rejection. And these 11 genes comprise the current day AlloMap assay. The 11 genes have to do with different aspects of the immune response, including steroid responsiveness, platelet function, T cell activation, migration, and proliferation, and so on. And there is an informatics platform that then assesses the expression of these 11 genes and comes up with a single score, a composite number ranging from 1 to 40. And the higher the score, the more likely acute rejection is present. Now know that the AlloMap test was only developed for surveillance for acute cellular rejection and not antibody-mediated rejection. So the subsequent study performed was to assess the performance of this gene expression test in a real-world cohort of heart transplant recipients to see whether it's actually a good test for surveillance for acute rejection. So this was the IMAGE study. It was a randomized clinical trial performed at 13 heart transplant centers in the United States and enrolled 600 patients. Half of these patients were randomized to a non-invasive surveillance arm using gene expression profiling, or the AlloMap test, and the other half of the patients were randomized to a traditional biopsy-based surveillance protocol. All patients had the same clinical assessments, imaging, and so on, but the patients in the non-invasive arm had rejection surveillance through the gene expression assay. And if the gene expression score was greater than or equal to 34, they would go on to have a biopsy. And if it was less than 34, they would not have a biopsy performed. The median follow-up was about 1.5 years. And the primary outcome was a composite of rejection with hemodynamic compromise, graft dysfunction, death, or retransplantation. You can see here that there was no significant difference in the primary outcome comparing the gene expression group and the traditional biopsy-based group. So basically, patients who had non-invasive surveillance had a non-inferior outcome compared to patients in a biopsy-based surveillance arm. And when we look at the individual components of the primary outcome, you can see that there were no significant differences in terms of rejection, graft dysfunction, or death. As planned, the patients in the gene expression arm had many fewer biopsies than patients in the traditional arm. Most patients had 0, 1, or 2 biopsies performed compared to many more biopsies, obviously, with a traditional biopsy-based approach. Now, the AlloMap test has a number of limitations. It has a low positive predictive value of around 7%. And this is partly because it was studied in a very low-risk patient population, so the prevalence of acute rejection in the study was quite low. It also is not validated for surveillance for antibody-mediated rejection. And finally, because it's a gene expression assay, it's affected by several clinical factors that can affect gene expression, such as CMV viremia. Even transplants in which the donor was CMV seropositive and the recipient was seronegative can sometimes have false positive AlloMap results. Patients should not be on high-dose steroids, defined as a prednisone dose of more than 20 milligrams a day. And also they should not have had growth factors such as G-CSF or blood transfusions within the past 2 to 3 weeks. So because of these limitations, we were still searching for other novel, non-invasive ways to screen for acute rejection after transplantation. And this is really where my group became very interested in cell-free DNA testing. And the idea initially came from the field of prenatal diagnostics, where you can detect DNA from the fetus or from the placenta in the maternal circulation as early as 6 to 8 weeks of gestation. And sequencing of the fetal DNA can allow you to detect genetic abnormalities in the fetus during pregnancy. And we hypothesize that the same situation exists in the setting of solid organ transplantation, where perhaps you can detect DNA from the donor in the recipient's blood, and maybe the DNA from the donor goes up in the setting of acute graft injury, such as occurs during acute rejection. So just a little bit of background on cell-free DNA. Cell-free DNA is released from all nucleated cells in the body, and it's released through normal cell turnover or apoptosis, or during episodes of tissue damage, such as necrosis. It can be found in any body fluid, serum, plasma, urine, saliva, and so forth. And it can come from genomic or mitochondrial DNA. And the fragment sizes vary quite a bit, which I'll talk about later. And finally, it's a very dynamic biomarker of what's happening in the body at that particular time, because it's rapidly cleared by the blood, by the liver and the kidneys, with a half-life of 15 minutes to several hours. So really, cell-free DNA really reflects cell turnover in the body at that particular time. So we started thinking about how we could detect DNA from the donor in the heart transplant recipient's blood. And for this, we took advantage of sequence differences. So we know that in the healthy state, there's a small amount of DNA from the donor in the transplant recipient's blood. And our hypothesis was that in the setting of acute rejection, there would be more DNA from the donor detectable in the recipient's circulation. And we also know that the donor and the recipient have sequence differences. And so we took advantage of this. By sequencing the donor and the recipient, we were able to detect their sequence differences, or to identify their sequence differences, and then use these differences to detect DNA from the donor in the recipient's blood. And the thought was, in the quiescent state, there would be a very low amount of DNA from the donor in the recipient's circulation. But in the setting of acute rejection, we wanted to see if there was an increase in donor-derived cell-free DNA. So in this field of heart transplantation, we performed a 3-year prospective study in which we enrolled 161 de novo heart transplant recipients at Stanford. We collected DNA from the donor and the recipient at the time of transplantation, and we sequenced them to identify their sequence differences. We then collected serial blood samples after transplantation for 2 years, and we isolated the cell-free DNA from the recipient's blood, and we sequenced it and were able to identify the cell-free DNA fragments from the donor and to quantify it. And what we found was that in the first few days after the heart transplant, there were very high levels of DNA from the donor in the recipient's blood. And this is because the graft sustains a certain amount of injury during organ procurement, during cold storage, and during ischemia reperfusion. And so that causes some graft injury, which leads to the release of DNA from the graft into the recipient's blood. However, that's rapidly cleared from the recipient's blood within the first few days after the transplant surgery, and subsequently falls to a very low, stable level in the absence of acute rejection. However, in the setting of acute rejection, we saw significant increases in the DNA from the donor that was detectable in the recipient's blood. And this is a patient who had a moderate cellular rejection, an antibody-mediated rejection, and a severe cellular rejection. Both cellular and antibody-mediated rejection cause graft injury and graft damage, and so both processes cause an increase in the amount of donor-derived cell-free DNA. We also found that DNA levels from the donor start to go up weeks to months before rejection is picked up on biopsy. So we know that this cell-free DNA assay is very sensitive for early graft injury that often is undetected on biopsy. And so clinically, I think this is important because it allows us to pick up graft injury very early and to potentially augment immunosuppression or start treatment early before rejection progresses to the point where it's picked up on biopsy, at which point it may be a very late stage and there may be irreversible graft dysfunction. So over the years, the technology has evolved such that the process has become much more automated and efficient and less expensive. And so the workflow has increased, the turnaround times have increased, the cost has decreased, and really this has become possible through the advent of next generation sequencing assays. So this allowed us to create a commercially available donor-derived cell-free DNA assay. So we collaborated with a medical diagnostics company called CareDx, which is based in South San Francisco. And what they did was they developed a donor-derived cell-free DNA assay that does not require sequencing of the donor and the recipient. Rather, it's a panel of 405 highly polymorphic SNPs that are reliably different between two different individuals. And so what they do is they collect DNA, the cell-free DNA from the recipient's blood, and only amplify this panel of 405 SNPs, and then use informatics approaches to infer which cell-free DNA fragments come from the donor and which come from the recipient. And they're then able to calculate the donor-derived cell-free DNA level, and that result is transmitted back to the transplant center within 48 to 72 hours. And this is called the Aloe assay, and it's commercially available for heart transplant monitoring in the US today. And it's also used for kidney transplant monitoring because, as you can imagine, the same type of assay can be used regardless of the type of organ that's being transplanted. So we studied the Aloe assay prospectively in a very large registry study called the DOR study. This involved enrollment of 740 patients at 26 heart transplant centers around the United States. And we collected serial blood samples after transplant and tested the Aloe cell-free DNA assay. And what we found was that in the absence of acute rejection, donor-derived cell-free DNA levels were present at very low and stable levels in the recipient's blood, with a median level of about 0.07%. But in the presence of acute rejection, whether it was cellular or antibody mediated, the amount of donor-derived cell-free DNA detected using this Aloe assay was significantly increased. And interestingly, as the rejection becomes more severe, as you go up to grade 2R and 3R cellular rejection, or PAMR1 to PAMR2, the amount of donor-derived cell-free DNA correspondingly increases. So there's more graft injury and there's more graft damage as there's more severe rejection. Not surprisingly, the amount of DNA from the donor increases in the recipient's blood. We also studied a group of patients who had graft dysfunction with normal endomyocardial biopsies, so biopsies that did not show rejection. And interestingly, the donor-derived cell-free DNA levels were significantly elevated in these patients, showing that they indeed had graft injury. And so I'm sure we've all seen these patients who had what we call biopsy negative rejection, or we thought maybe the biopsy was inaccurate or it missed the rejection, or maybe the biopsy read was inconsistent. But in these cases, we can clearly see that the cell-free DNA assay is very sensitive and it is picking up graft injury. So it may even be more sensitive than the biopsy for detection of acute rejection. So overall, in the DOR study, at a threshold of 0.2%, the Aloe assay had a sensitivity of 44%, specificity of 80%, a positive predictive value of 9%. Again, the prevalence of acute rejection in this cohort was quite low, but importantly, a negative predictive value of 97%. So if a patient's cell-free DNA level falls below the threshold, you can be 97% confident that acute rejection is not present. So it's an excellent assay for non-invasive surveillance, which allows us to avoid biopsies when a patient is clinically stable. But also I'd like to emphasize that since the assay is quite sensitive for early graft injury, it's possible that some of the elevated Aloe results that did not correlate with biopsy-proven rejection were actually picking up very early signs of graft injury. Subsequently, a group led by Dr. Hannah Valentine and Dr. Sean Agborino at the National Institutes of Health did a very similar study using a similar donor-derived cell-free DNA platform. And what they did was compared donor-derived cell-free DNA patterns in acute cellular and antibody-mediated rejection. And what they found was that donor-derived cell-free DNA levels were significantly higher in the setting of AMR, and they also started to rise earlier with AMR. And finally, they showed that the fragment lengths were different in AMR and ACR. And so my hope is that in the future, we can use different cell-free DNA characteristics or patterns to help us distinguish different subtypes of acute rejection. So that was the data to date in the field of heart transplantation. And I'd like to spend a few minutes talking about non-invasive surveillance using donor-derived cell-free DNA in lung transplantation. So we did a very similar prospective study at Stanford where we enrolled de novo lung transplant recipients and measured their donor-derived cell-free DNA levels. And what we found was that in the absence of rejection, patients initially have very high levels early after transplant, which then go down, but then you see this slow and progressive rise in the donor-derived cell-free DNA levels over time in lung transplant recipients, indicative of some low-level tissue damage. And this may occur because of development of chronic lung allograft dysfunction or perhaps infections within the allograft. But we did find that during episodes of acute rejection, the donor-derived cell-free DNA levels did increase significantly above the baseline levels. Now, the group led by Drs. Valentine and Agborino at the NIH collaborated with a consortium of lung transplant centers along the East Coast in doing more lung transplant studies of donor-derived cell-free DNA. And what they found was that in the setting of acute rejection, donor-derived cell-free DNA levels were significantly elevated after lung transplantation. And they also showed that early donor-derived cell-free DNA levels within the first 3 months after lung transplant accurately predicted subsequent allograft failure. So patients with the highest levels of donor-derived cell-free DNA within the first 3 months after lung transplant had the highest risk for early mortality, or sorry, for subsequent mortality after lung transplantation. So this seems to be a very sensitive prognostic biomarker as well. Patients with higher levels had 7-fold increases in allograft failure and 4 times the prevalence of antibody-mediated rejection compared to patients with low donor-derived cell-free DNA levels after lung transplantation. They also found that in the setting of antibody-mediated rejection, donor-derived cell-free DNA levels start to rise months before AMR is detectable clinically. So again, this is a very sensitive assay for early detection of graft damage after both heart and lung transplantation. Now, cell-free DNA assays do have limitations. For example, in the setting of other solid organ transplants, such as kidney transplant, it's possible that the cell-free DNA levels from the donor can be elevated during graft damage that's not due to acute rejection, such as infections of the allograft, as may occur in pyelonephritis or other types of acute kidney injury. Also, donor-derived cell-free DNA levels should not be assayed in multi-organ transplant recipients because we cannot tell which organ the donor-derived cell-free DNA is arising from, and different organs have different thresholds for acute rejection. It should not be performed in the cases of, for example, a kidney transplant from a monozygotic or identical twin, in recipients who are pregnant who may also have circulating fetal DNA, patients with active malignancy in which you may pick up circulating tumor DNA, and finally, in the very early time points post-transplant where patients still have resolving allograft injury. And finally, I think the big question that's still out there is how do donor-derived cell-free DNA levels guide our clinical care? And in the United States, there are actually several prospective randomized clinical trials that are about to be launched of immunosuppression modulation based on cell-free DNA levels. So in conclusion, donor-derived cell-free DNA has the potential to be a very informative, non-invasive marker of acute rejection after solid organ transplantation. It may enable clinicians to non-invasively distinguish acute rejection from other complications after transplant, and this results to fewer biopsies being performed, which leads to fewer procedural complications and more satisfied patients. We do a lot of non-invasive surveillance at Stanford, and I have not seen biopsy-induced tricuspid regurgitation in a long time. And certainly patients are happier not having to have routine biopsies. It may permit early detection of graft injury before graft damage occurs. And also donor-derived cell-free DNA levels fall after treatment of acute rejection, so can be used to assay response to treatment. Finally, donor-derived cell-free DNA outperforms many other available non-invasive biomarkers of acute rejection after solid organ transplantation. So this field has rapidly exploded over the past decade, starting with our first publication in 2010. Now there are approaching 40, even 50 new publications on donor-derived cell-free DNA testing in the field of solid organ transplant every year. And I think with that, interest is growing, clinical applications are being tested, and this is really a very novel and exciting field to be involved in. So with that, I'd like to end my presentation. I'd like to thank you very much for your kind invitation and for your attention today. And I would like to thank all the people who contributed to this work. Thank you very much.
I think we should thank Dr. Kiran Kush for this very wonderful presentation. And I think cell-free DNA now, donor-derived, is now already provided in India, in Lalpan. And of course, the role of Aloe also is probably established in US at least, in the biopsy intervals, and more as a negative predictive test. So Dr. Bhagirath, you wanted to?
Yes, two questions to Dr. Kiran Kush. Number one, in the case of AMR, the patient is often on corticosteroids. Can you hear me?
Dr. Kiran is not there.
Yeah, they're not alive. Yeah.
She's not live.
So just for discussion, many times the patient.
One second, maybe Jasmeet can answer the questions.
Yeah,
all right. Anybody, I just want anyone from the panel to answer. Many times, especially when you are assessing AMR by this new technique of cell-free DNA, the patient is concurrently on steroids. So that would interfere with the value. So I'd like to know how you would interpret the value in such cases, question number one. And question number two is, we have more or less in Dr. Kush's published data, you have cutoff values corresponding to grade 0, grade 1, grade 2, and grade 3 in ACR, and 0, 1, 2 in AMR. But what happens if both ACR and AMR are there concurrently? So, are there a different set of values, or how do you interpret?
So I'm making an effort to attempt to answer the question there. So the first question regarding interference of steroids with the values of cell-free DNA, it does not occur, because cell-free DNA has been extensively validated in the heart, lung, and the kidneys to monitor post-transplant. So steroid per se will not interfere with the values that one gets from the test. So that is one. And secondly, when concomitant antibody-mediated and cell-mediated rejection are present, the values will not get affected. But yes, the values of cell-free DNA are directly proportional to the amount of injury to the transplanted tissue, which could be because of apoptosis or it could be because of necrosis.
Yeah.
So if you were to compare the values of antibody-mediated rejection with cellular-mediated rejection, the values in antibody would be more because it's directly proportional to the injury. So that's how the values work. So
my reason for asking this question is, in the published data, it says 0.7% for grade 0, 0.8 for grade 1, and then 0.15 for grade 2, and so on. Whereas in antibody-mediated rejection, also the values are pretty similar. That's why. Of course, later on the values go much higher in AMR. Yes, but in the initial phases, it may be, there may be an overlap in cutoffs.
Yeah, it may be difficult to differentiate.
Dr. Jasmeet, what is your cutoff value in your?
So, so it's the same which has been recommended by the CareDx. So there's no difference.
0.2% threshold allows and all that. With
yes. So the test we are using and we have validated is from CareDx, which is the same which has been validated by Dr. Kiran Kush. And it's just that the name of the test is AlloSure in the US, and it's AlloSeq as a commercially available test, but the test would be the same. So that is, and the values and cutoffs all remain the same. The test methods, the techniques are the same, absolutely.
Bhagirath, the DOR study, I mean, and the part of it which they did from Stanford and Sinai, the AMR values were, I think, much higher, what they found. I mean,
Yes,
2 times.
so that's exactly what I was trying to say. The values and the antibody-mediated rejection are higher than in the cellular rejection. But yes, if both are present, you will not be able to differentiate, and the values would be like a mixed
overlap.
So, Dr. Jasmeet, 2 things. One is, what about younger age patients? And what about patients after blood transfusion? You think it would confound
Yes. So after blood transfusion, 30 days, there is no collection of sample for this unless it is leukodepleted. That's one, because we would expect some amount of fragmented and broken cell-free DNA from the donor. So 30 days is the cutoff if it is not leukodepleted, but if it is leukodepleted, we're okay with it. The only other thing we need to remember is that if you are going to send a cell-free DNA, it must be sent before the biopsy. Otherwise, it takes at least 24 hours after the biopsy. And the reason for this is that the half-life is very short. So even 24 hours is a good enough gap between the cell-free DNA and the biopsy.
Dr. Jasmeet, one question is, within 28 days, you still go for the conventional biopsy because the values are still high, and definitely we would want to assess the donor organ within the first 28 days.
So like Dr. Kiran Kush brought out in her talk, it has a very high negative predictive value at 97%. So if the donor-derived cell-free levels are not high, you do not have a rejection. Yes, if you get high values, it will definitely help you in targeting and being more specific and precise in taking your biopsies and at what time to go ahead and do a biopsy. So that is important to know. That is fantastic negative predictive value of the test.
But the first 30 days after transplant, I think it would be a confounding lot of, I don't think it is.
Values are still high.
That would be confounding.
So the factors which would confound the test just after transplant would be that you do not do it for the first 14 days after the transplant, because that's the time one would expect some amount of injury to have occurred to the transplanted organ, the ischemia, cold, warm ischemia time, and therefore give that much time for the values to settle down and then go out and take a sample.
Now, clinically, Dr. Bhagirath, I think this Aloe map, of course, is not available in India, but I think it's FDA approved, but mainly for ACMR.
Yes.
And I think Dr. Kumud also, if he can comment, I think that there's one trial probably coming up called SHORE trial, Surveillance Heart Care Outcome Registry. So just to see the value, as Dr. Kiran has mentioned, where does it all this test stand from a clinical point of view? So should we combine both Aloe map, Aloe? Or we depend on biopsy also in the interval period. So what do you think?
So I think Aloe map is looking at the gene expressions, and why it is more important for acute cellular rejection is that it looks at the various genes which are expressed in T cells, platelets, and other markers which are upregulated in cellular rejection. So Aloe map and AlloSure jointly is what is the heart care in the US has fantastic predictive values, yes. So one is great for acute cellular and one is for antibody-mediated rejection.
Dr. Uma, welcome. Would you like to comment, Dr. Uma?
I think you already had a very good discussion. I'm sorry, I think the session timings didn't tally with the previous ones. I think what Jasmeet has given the explanation that the early 2 weeks, I would say the studies have indicated probably 3 weeks is a good time, and then after 3 weeks is the best when you can start assuming that we will get the real values. And the good point is the negative predictive value. So that really assures that what we are getting is actually what the status is. if you want to use that for a future management of the patients. That's the idea. Only thing is the cost now, and also the sample shipments when they are sent from one center to the other. One has to be very careful with that.
So Uma, I'd like to just come in and comment on the sample shipment. It's on plasma. These samples are very good, but yes, one does have to make provision for the very specific Streck tubes for transportation. Transportation is at room temperature. Streck tubes can maintain the plasma and cell-free DNA for 7 days, but yes, we would recommend within 2 or 3 days for the sample to reach us. And I want to here share my experience about 50 samples we have processed already in India, and we've not had a failed sample to date. Not many from the heart, predominantly from the kidney, but yes, very reproducible results and extensively validated.
So all the clinicians, I mean, everybody likes to have good assays and all, but then sometimes we do feel even within the hospital, you know, the laboratory and the, you know, wards and the theaters need to be very well aware of what kind of samples and how to ship them. So once that coordination is there, I think the test results are absolutely good. So, and especially few centers in India are doing, samples will have to be moving from one center to the other across the cities. So everybody needs to realize that that's really a very crucial point, because then otherwise the results are not reliable.
Just a final comment in that this is really good talk, and this is where the future is. However, I think in adopting something new, we do have to be careful about the logistics, about everybody jumping on something that really requires further evidence for all solid organs. And so I would urge those wanting to do this, please, to keep the data, collaborate with the others so it's done as a proper trial. And so we really can then use that data to evolve the practice, and hopefully we could stop doing so many actual surgical biopsies. And on that note, I think we should end and continue with the next talk. Back to the chairs.
Thank you.
So the next talk is on the quest for immune tolerance, and the chairpersons are Dr. Uma Kanga, Associate Professor, Department of Transplant Immunology and Immunogenetics, AIIMS, New Delhi, India. She has been the Secretary of Indian Society for Histocompatibility and Immunogenetics and the Vice President of Asia Pacific Histocompatibility and Immunogenetic Association. And the other chairpersons are Dr. N.K. Mehra, Immunologist and HOD of Transplant Immunology and Immunogenetics of SIL Gurgaon, and the former Dean of Research and holds the ICMR Dr. C.G. Pandit National Chair at AIIMS. And we have Dr. P. Mohanan, who is a consultant cardiologist and the Director and HOD of Cardiology at Westport Hospital, Thrissur, and the National President of the Cardiological Society of India. And the speaker is Dr. Jasmeet Kaur. Over to the chairpersons.
Dr. Uma, you can just begin.
Okay, so it's my pleasure to introduce Jasmeet. She has been trained at the Army Hospital FMC for her MD pathology, and during her PhD, she was a student in our department at AIIMS, Transplant Immunology and Immunogenetics, and we had good interactions during her thesis on stem cell transplant. Post that training, she has been working with the armed forces for quite a long time and been a part of the solid organ and bone marrow transplant teams. And she is now working at the Lal Path Labs and handling the transplant immunology department there. So welcome, Jasmeet, and it's a pleasure to join the team here. So, floor is yours.
Thank you, Uma, for that introduction. Yes, I was with the Army for many years and at AIIMS for 3 years to be in the Department of Transplant Immunology. So I'm going to take you back from cell-free DNA to the basics of immunology, and I hope you will bear with me when we go through some of the initial slides, and that's the quest for immune tolerance in transplantation. Oh, why is that not moving? Sorry, but I think I'm stuck, yes. So looking at immune tolerance, what is the definition? Now, immunological tolerance occurs when an immune competent host fails to respond to an immune challenge with a specific antigen. So it is a state of unresponsiveness specific for a given antigen. It is a specific negative immune response and is induced by prior exposure to that antigen. The most important form of tolerance, as we know it, is non-reactivity to self-antigens. But the question here is it possible to induce tolerance to non-self antigens? It is different from non-specific immune suppression, which is something which we will need to focus on when we are talking about tolerance in transplantation. And of course, tolerance is also different from immune deficiency. It is an active antigen-dependent process in response to the antigen. Tolerance is specific. It's known to occur in T cells, B cells, or both. It has immune memory, and tolerance in the T cells is longer lasting than tolerance at the B cell level. Looking at tolerance in organ transplantation, of course, the best immune suppression is no immune suppression. And that's the focus and the promise that immune tolerance holds maybe in the future. In transplantation, tolerance is defined by the graft must be accepted without any lesions of rejection. The recipient should not be an immunosuppressed treatment, and the recipient should be immune competent, that is able to mount an immune response to other foreign antigens. So a little bit of basics here, and I hope you can see the pointer. So when we talk about tolerance, there is a central tolerance and a peripheral tolerance. So central tolerance, mainly the thymus and the bone marrow, and the main processes here are clonal deletion and regulation, which is in the form of T regulatory cells. So this is where the education occurs of the developing T cells from the dendritic cells. Then, of course, we have peripheral tolerance, which can be in the form of deletion, energy, apoptosis, and ignorance. Central tolerance and its mechanism of action is the lymphoid cells go through maturation in the thymus, to clones which are not specific to self-antigens present in the primary lymphoid organ. And then there is maturation of clones that suppress the self-antigen recognition. So one half is the regulatory self-development there. And the second is that clones which are not specific to self-antigens are present and sent to the peripheral circulation. But when we look at the peripheral tolerance, there is mature lymphocytes. It can occur through apoptosis, which is breakdown and disintegration of cells, through energy, where that's rendered ineffective, or through regulation, which is mediated through the T regulatory cells. Now, tolerance induction strategies over the years have focused on various techniques. The first is inducing a state of mixed chimerism. Then there are cell-based therapies, and a lot of research is still going on about T regulatory cells, the B regulatory cells, various dendritic cell subsets, and the mesenchymal stromal cells. There's also co-stimulation blockade, which is applicable here, and of course, thymus transplantation, which is probably still under experimental stages. Now, looking first at chimerism and the engraftment process. This is a process which is well documented and being practiced in bone marrow transplant. So what chimerism actually looks at is and analyzes the used to determine the genotypic origin of post-transplant hematopoiesis. So the concept here is there is a recipient, a donor, and you get a state of mixed chimerism, which is the middle state where there are T cells, B cells, to which the dendritic cells present the MHC antigens here, and these T cells of the donor as well as the recipient undergo negative selection. So the new T cells that develop post-bone marrow transplant in the recipient interact with the peripheral dendritic cells and then bring about clonal deletion or negative selection in both the groups. So looking at chimerism, and we do monitor this routinely in clinical practice as well, there is a state of complete chimerism post-transplant, which a bone marrow transplanter would hope, But if you're looking at tolerance, we would want a state of mixed chimerism. And then within the mixed chimerism, one would want a state of stable mixed chimerism. So mixed chimerism therefore refers to a sustained state in which a mixture of host and donor cells compose the lymphoid and the hematopoietic elements of the recipient. Allograft tolerance and its role in chimerism. So the principle here is that mixed chimerism could actually lead to long-term donor-specific tolerance. And based on this, there have been 3 major studies. The MGH study, where they induced a state of mixed chimerism in patients with multiple myeloma and renal failure who needed a bone marrow as well as a renal transplant in HLA-matched siblings. Now, they initially took up 6 patients in the study, and all patients developed tolerance and were able to be taken off immune suppression. But when they extended the study to HLA-matched non-siblings, the results were not the same as those with their previous work. So the limiting factor they found here was the engraftment syndrome, where they've realized the patients would lose peripheral chimerism and regain the host-derived hematopoiesis element, and the patient would then have to go back to immune suppression. This approach, however, allowed successful induction of transient chimerism in patients, which was a state of tolerance, but long-term development of stable mixed chimerism was not observed, and long-term operational tolerance in these patients, in these individuals, was variable. So we looked, another study was by the Stanford group, and they talked about inducing a state of transient chimerism with HLA-matched transplants, and the 70% of these patients were able to be taken off immune suppression. But induction of chimerism and subsequent immune suppression withdrawal was not achieved in HLA mismatched transplant. So in both these studies from the MGH as well as the Stanford group was that they were not able to induce this in HLA mismatched transplant. And probably that was because the different immune suppression, different myeloablation techniques that were used. The Northwestern study did HLA mismatched kidney transplants with TBI and myeloablative, which is a far more intensive form of conditioning before the transplant. They were able to achieve full donor chimerism, but they also suffered the consequences or the limitation of having a full donor chimerism, which is development of graft versus host disease and increased mortality. So the approach was to generate a durable full donor chimerism, have had a low risk of subsequent rejection, but limited clinical applicability due to the potential of development of severe GVHD. In contrast, tolerance induced by transient mixed chimerism was not associated with GVHD, but the protection against allograft rejection has been unpredictable in these patients. Therefore, improving the consistency and safety of chimerism approach will need to be done to broaden the scope of this strategy. Moving on to the regulatory cells in transplantation tolerance. And regulatory cells were important 30, 40 years ago, where they were called the suppressor cells, but they've gained a lot of importance again in the recent past. And we look at the thymus here, and it has 3 types of cells. Cells which would have low affinity for self-antigen. These T cells would mature and move into circulation. A second group of high affinity of self-antigen, and this is part of the thymic training that is happening. These would undergo apoptosis and die out. And the third group, which have intermediate affinity for self-antigen. Now, these cells are the ones where the FOXP3 would get upregulated in these cells, and then they would move into circulation as naive T regulatory cells. And the role of the naive T regulatory cells would be then to suppress the reaction of self-antigen. And if you look at the mechanism of how it does this, is the regulatory T cells cause inhibition of T cell activation and inhibition of T cell effector functions. So, sorry. The mechanism of regulatory T cell action is here. When these CD4 positive T cells interact, or the T helper cells interact with a dendritic cell, which is here, the T regulatory cells could suppress the function of both those which are T effector cells and T effector cells for the B fraction. The other mechanism which is important in T regulatory cells is the CTLA4 mediated inhibition of dendritic cells. And that is that the CTLA4, now we know that the activation of the T cells by a dendritic cell would not happen in the absence of a co-stimulatory signal. So the CTLA4 here is the one which could be would mediate inhibition of the activation of this interaction and hence bring out inhibition of various cytokines like TNF-alpha, IL-6, as well as activation of the cells. So the T regulatory cells were studied in human kidney transplant have shown an increased number of intragraft FOXP3 T regulatory cells which have a favorable graft outcome. So one would definitely want to see a higher proportion of T regulatory cells within a graft to predict or to presume the graft outcome would be good. So the approaches to T regulatory cellular immunotherapy has been either polyclonal or monoclonal. In the polyclonal, it is antigen non-specific T regulatory cells which are part of the immunotherapy. The recipient T regulatory cells here are isolated, purified, and expanded and reinfused. So they're non-specific T regulatory cells, and therefore the current studies that are underway are to determine the efficacy, because we are looking here at donor-specific T regulatory cells, which is what we get from the monoclonal T regulatory cells, most effective in preventing rejection and inducing tolerance. There is low risk of non-specific immune suppression. Of course, what's even newer is the development of chimeric and antigen receptors expressing the T regulatory cells. So when we move on to the peripheral tolerance and co-stimulatory blockade, an interaction between the antigen presenting cell, which is a dendritic cell, and a T cell there's a primary signal, which is the antigen on the APC interacts with the T cell. And then there are co-stimulatory signals. So the first signal is the cognate antigen receptor. The second are co-stimulatory molecules, which is CD28, AT86, or CD40 and CD40L, and those which act through cytokines that promote expansion of the interleukin-2 clone. Now, looking at the peripheral co-stimulatory blockade, that's an APC and CD40-40L, CD8086 and CD28 here, and CTLA4. So the CTLA4, anti-CTLA4 has been found to be a fantastic agent to block this signal here and hence prevent the activation of the T cells. So synergistic use of CTLA4 antigens and anti-CD154 monoclonal provide long-term tolerance, but this was in non-human primates. So when they tried to extrapolate this onto humans, they realized that the anti-CD154 had massive anti-thrombotic effects. So they had to take that off, and the focus then shifted to improving the efficacy of CTLA4, where they have brought in molecules with altered amino acids for CTLA4. Then moving on to the function of the dendritic cell subsets in cardiac transplant. Now, briefly about the dendritic cells, which are the antigen-presenting cells. They are the classical dendritic cells and the plasmacytoid dendritic cells. The classic dendritic cells perform the function of presenting antigen to the T cells efficiently, giving rise to a proliferation and activation of CD8 as well as CD4 positive C cells. What we want to look at is the plasmacytoid dendritic cells. Now, these cells are have weak antigen presenting capabilities. And the plasma dendritic cells are able to induce the development of the CD4 positive, CD25 positive regulatory T cells. And we've already seen how the T regulatory cells are important and how useful they are in bringing about tolerance. So the relative composition of dendritic cell subsets in the peripheral circulation depends on two factors: the choice of the immunosuppressants used and the time from transplantation. In a study of human heart transplant recipients, the lower level of plasmacytoid dendritic cells, and there was an association with increased rejection rate. They also looked at the immune suppression used there, and we compared tacrolimus to cyclosporin as immunosuppressive therapy. And TAC has significantly higher values of plasmacytoid dendritic cells than cyclosporin-treated patients, and therefore decreased rejection, which obviously implied that tacrolimus was better at increasing the levels of promoting the plasmacytoid dendritic cells. Studies directed at plasmacytoid dendritic cells have looked at adoptive transfer of plasmacytoid dendritic cells associated with prolonged graft survival. And these dendritic plasmacytoid dendritic cells promote the T regulatory cell development, a role in both induction and maintenance of tolerance. Now, impact of various tolerogenic therapy on the dendritic cells. So we looked at CD40L blocking agents, and when you block this here, what you get is a decreased production of various cytokines, which we know can be harmful and also promote T cell proliferation. There's also upregulation of negative co-stimulatory molecules here by blocking this, which is the PDL1 and PDL2. They yield an inhibition of the T cell proliferation, thereby moving the patient towards tolerance. But what is a problem and is being focused at is the activity of the exosome production. We now know that exosomes are also very significant in presenting the antigen, or what is called the dressing of the antigen presenting cells. There is, of course, a lot of focus on the epigenetic modulation and the TAM receptor involvement in dendritic cells and in the research as it is today. And then looking finally at the B cell signatures for tolerance. We all are familiar with the donor-specific antibodies, and these antibodies are produced by the antibody-secreting plasma cells. And the DSA can be either preformed or de novo. A lot of pharmacological effort has gone into developing techniques of decreasing the production of antibodies from the plasma cells. So anti-CD20, rituximab, anti-CD19, proteasome inhibitors have been in use and practice for multiple conditions, including transplantation and desensitization for a long time. But the new cells we're going to look at are the B regulatory cells. Now, these B regulatory cells preferentially secrete immunosuppressive cytokines. Now, IL-10, IL-35, interleukin 10, interleukin 35, and TGF-beta. Because there is no specific markers which will locate the regulatory B cells which produce large quantities of interleukin 10, they are called the B10 subset of the B regulatory cells. The tolerant patients have been shown in various studies to have more of IL-10 producing B cells in their blood. So that's a positive finding as far as the B regulatory cells are concerned. So finally, to conclude, most studies have looked into the impact of tolerizing therapies and by delivery of apoptotic cells, co-stimulation, blockade, and acting on dendritic cells through upregulation of inhibitory molecules and T regulatory cells and reduced cytokine secretions. But areas of future research include the implications of immunometabolic modulations, interrogation of regulatory dendritic cell receptors, such as the TAM family with nanobiologics, and the thymic transplantation of the donor thymus which has not yet had any human trials, but yes, they have tried in non-human primates. And with that, I would thank you all for this, and I'm happy to take any questions.
Thank you for that very comprehensive journey through immune tolerance, Dr. Kanga. Back to the chairs for any questions from the audience or yourselves.
Thank you, Dr. Jasmeet. As a regular, run-of-the-mill cardiologist, most of the things that you have discussed go above my head. But then I just wanted to know whether the double organ transplantation has any benefits to tackle this immune tolerance now, because pharmacologically we don't see much of these, even though we have chimerism, cell-based therapies maybe coming in the offing. What is your opinion about the double organ transplantation and the immune tolerance?
So a double organ transplant has been done, and people have looked at hand transplant and look at the liver and the heart transplant together. So there are studies which are there which have said it can help with induction of tolerance, depending on the timing of transplantation. If they're going to look at a bone marrow transplant and what they called a non-myeloablative or a mini bone marrow transplant, which is followed up by a kidney transplant, because I don't think anybody's done a heart transplant. I'm not aware of literature there, but kidney, yes, has been done in a lot of centers. They did find a lot of tolerance, but the issue and the confounding factor there itself remains the maintenance of a state of mixed chimerism. You don't want it to become a full-blown donor type, because that has its own consequences and side effects and increased mortality. And if you cannot maintain a mixed chimerism and it falls too low, there will again be no tolerance. So eventually all these patients would go back to the immune suppression therapy. So the question is that what is the best technique finally we will adopt? So maybe
what is your gut feeling? Will we see some cell-based therapy like HSMT in the offing?
I think yes, definitely. With the reading that I've been doing, there is a lot of cellular immunotherapy in the field of dendritic cells. There's a lot of work that has gone on, and the classification of dendritic cells and trying to work. It will take time, definitely, to reach the clinical practice, but it's something we can look forward to. And even the CAR T regulatory cells, we are already using CAR T cells for in oncology, and I don't see why they are not going to be available for transplant. So hopefully.
Jasmeet, you alluded to the use of bone marrow transplantation before the solid organ transplantation. So there have been reports stating about, not the full bone marrow transplant with the ablative therapy, but, a DLI, and that infuses, tolerance, and then the transplants have been done. Like the center in Ahmedabad, the IKDRC, they started with that. And I think some of the centers in US also have observed good results. So would you like to discuss a bit on that?
Yeah. So
GVHD is less, and I think it induces tolerance, and then it helps in solid organ transplant.
Yes. So what I talked about in bone marrow transplant is a mini transplant or a non-myeloablative transplant, which is a less toxic conditioning regime out there. It has an issue of maintaining that state of mixed chimerism, because I showed that slide. Chimerism, if it's mixed, has a tendency could go up or could go down, so increasing or decreasing. So maintaining that state is the issue there. And if that can be maintained, there is definite good thymic training of the donor origin T lymphocytes as well as the recipient T lymphocytes, which of course is there. As far as a myeloablative conditioning is concerned, that is toxic, and it's a challenge even for the bone marrow transplanters. So to do a myeloablative transplant for a heart transplant would really would require a lot of effort and difficult to do, I should think. But yes, But yes, a few studies have looked at giving donor-specific transfusions or donor-specific lymphocytes to, again, the whole purpose is to educate or bring about a central tolerance of the recipient to the donor cells, and then go out and do that. So that all has been done. It has shown results, but like I said, the challenge remains in maintaining that state of stable chimerism. So if that can...
Yeah, the issue here is, I think, in live-related transplant, you can still look at donor-specific, but when you have a, deceased donor transplant, especially heart and lung, there it's difficult to manage. So also depending on organ to organ, the management and the therapies to induce tolerance can vary. So what we can apply in a live-related program cannot be applied always to a deceased donor program. And so it's like the heart transplant. So we also have to think about that and keep that in mind. But definitely these are adaptive immunotherapy is what is going to be the future for solid organ transplants. And that's going to help. So if there are any questions from other participants or anything, it would be nice to take them now. Anyone, any questions?
If there's a last question, we just have enough time.
Okay.
There are none. I don't think the chairs have received any from the audience.
We haven't got anything on the chat box yet.
No. Okay, listen, it's almost 5:35, so we'll carry on with the next talk, which is on xenotransplantation. And this was actually going to be given by Mandit Mehra, the chief editor of Journal of Heart and Lung Transplantation, and a very distinguished person, previous president of the ISHLT, currently the William Harvey Distinguished Chair in Advanced Cardiovascular Medicine at Harvard, and medical director of the Heart and Vascular Center at the Brigham and Women's Center in Boston. Unfortunately, he is not here, but he has sent me his slides. So I'm going to give his talk. And in doing so, let me just share the screen with you first, and I'll explain what I've done so it makes sense. Now, let's see if you can see this. Hopefully you can see this. Yes. Wonderful. So everything you see in orange are my additions, which are really here to simplify and clarify a few aspects and some things I thought might be good to put in. So without further ado, this is really an evolution of, I guess, the thoracic heart transplantation, what's happened ever since 1967 with the Cape Town transplant, to that arrival of immunosuppression and the end of that terrible mortality during that phase where so many centers gave up transplants altogether. And then we've had lots of other improvements in immunosuppression, of course, statins and other therapies that have improved survival rates, which by, as you can see, in the 90s and 2000s, survival rates had already gone beyond 90% at 1 year. And now coming to this last decade and now in the future, what really are the challenges? And he puts down there the scarce donor pool, imprecise immunosuppression, despite our prolonged use of such, infection remains an issue, antibody-mediated rejection increasingly recognized as an important feature in terms of survival of our patients into the medium to long term, what to do about accelerated coronary vasculopathy, and of course, solid organ cancers remain an important issue, not just in terms of recipients with previous cancers, but of course, more importantly, in postoperative limitation of myeloproliferative disease. And what are the opportunities? He's listed down in terms of DCD heart transplantation, hepatitis C, and of course, HIV in South Africa, particularly. Gene editing with CRISPR-Cas9 technology that is going to, I think, finally bring around xenotransplantation, desensitization, and of course, improving, again, addressing the coronary artery disease and cancer and so on. I have added others, which I think are going to be in respect of heart replacement, so cellular constructs, regeneration of the tissue itself, improvement of immune tolerance, and artificial advanced artificial organs, untethered, that will last longer, potentially, for decades as opposed to just a few years, and prevention of cardiovascular disease in general. So pigs have been the foremost model for us in looking at xenotransplantation. And why? Well, there's some Winston Churchill's quote as to how we respect the pigs and vice versa, probably. I have put in there some very important quotes from my own hero, Peter Medawar, probably the father of transplantation, and of course, Warwick Kahn, who brought immunosuppression to us in the form of cyclosporin. And of course, the problem is that, which is thrombotic microangiopathy that occurs in that acute rejection phase. And this is a famous quote from Norman Shumway. But I think that future is not always going to be in the future. And this is some historical notes on what has been done before in terms of concordant cardiac xenotransplant. You will see those are only highlighted within that blue boundary. The rest are actually discordant. And I will just, if I can, so this is the first one was actually James Hardy's first transplant of a chimpanzee to man in a really poor recipient that we would never consider now with a terrible atherosclerotic disease, bilateral low limb amputation and semi-comatose. The other one, of course, is Leonard Bailey's and baby Faye. Oops, sorry, let me just go back. And baby Faye using a baboon to this neonatal baby who survived 20 days. And then, of course, not to forget what's happened in India itself, and probably the first sort of porcine to man heart-lung transplant. Now, many in the audience who might be able to correct me, what I can find is that it's sometimes there's heart, sometimes there's heart-lung transplant in a 32-year-old farmer at the Heart City in Sonam, Assam by Dr. Barua and his colleague from Hong Kong, Dr. Ho Kei-shing, in 1997, with the death occurring at day 7 with the PM showing infection as the cause of death. And poor Dr. Barua, of course, was at that point arrested and jailed, and he was going to sue the government. I'm not quite sure what has happened since, but certainly it has been attempted. What about in terms of discordant xenotransplants? Well, let's look at the evolution of this whole idea of how similar species can be. And if you do that, then of course we are closer to the mouse than we are to the pigs, where we separated from much earlier in time, nearly 90 million years ago, and only about 70 from mice. And then when you look at why, again, the pig versus the baboon, there are many characteristics that the pigs have which are extremely similar, not least in terms of weight, physiology. Both porcine human physiology are concordant to about 85%. And there are a few genetic similarities and of course many differences, but nevertheless, most of those things that you'll see on that column show that we have actually surprisingly quite a lot of similarity with our porcine friends. Now, what's been the worry about xenotransplantation? Why has it always been something for the future? So I just want to go through some really basic stuff. So signs are really short segmented interspersed elements. They're normally considered to be such as junk, selfish or parasitic DNA, and thought to have arisen and inserted into our own genomes or that of the pig from evolutionary viral presence. Now, the most common one in man is the allele-transportable element derived from a cytoplasmic RNA. And this appears to be exactly the same as the original source of the common swine sign. And therefore, some are arguing that maybe we do have far more genetic similarity with pigs than considered till now. But that remains a bit of a debate. However, the main immunological problem in respect of xenotransplantation comes down to a single gene, and that's the galactose alpha-1,3 galactotransferase, or the GAL transferase, or GAL-T, or alpha-GAL-T, I should say, which present in everyone, all mammals except humans and higher apes. And so the advance in xenotransplantation relies in eliminating this gene from the pig model, the xenotransplant model, with addition of other perhaps beneficial human genes as well. And this is what happens in that acute rejection, hyperacute humoral rejection with histology, which, as you can see, is resulting from specific antibodies to HLA more than ABOs or other antigens. It's a rapid, irreversible graft destruction. with it, you can see there's a massive polygonal leukocyte infiltration, and you get this interstitial hemorrhage, edema, and so forth. That's you can see. So this really is describing just this, what's happening in terms of complement activation, in terms of anti-gal, what we do with the alpha-gal epitope on the porcine cell surface. And this is really what's happening, which you've seen before in that earlier slide. But coagulation and the coagulation pathway is another thing that is extremely important in trying to see how we can get better outcomes from xenotransplantation. And I'll come on to that. And much of what has already been said in the previous talks will hopefully converge. So what are the obstacles? Well, we have these GAL3 alpha-gal antibodies causing hyperacute rejection. What do we do about that? There's some other non-gal antibodies, T-cell mediated rejection, coagulation problems, and the threat of zoonosis. And this is in a sequential time order. So if we look at what's happened from the start of experimentation with xenotransplantation and survival outcomes in terms of days on the left-hand column, and the trajectory in terms of time over what has been instituted, then you can see that from roughly a 15-day survival in very few numbers to really 96 days coming up to now with various strategies, which I've tried to make simpler by because these are the three things that we need to do to get better outcomes from xenotransplantation. One is to have this knockout, so we knock out the alpha-gal T from the porcine model. You then need to have some transgenic expression of the human complement regulatory proteins, forgive my spelling errors. And then finally, you need to have a transgenic and effective induction and maintenance of immunomodulation. So really immunosuppressive strategies that are known also to help. And we will go into this all in a little bit more detail. So it is a multi-pronged approach to try and improve outcomes and see if we can ever bring it into the clinical arena. We've already heard about co-stimulation, whether it be T cells or potentially B cells also, something called recipient accommodation, the control of the innate immune system with reference to, for example, natural killer cells, and to overcome the issues of coagulation between the species. I'm going to try and explain that a little better by taking each one of these in turn. So the Aloe immune response in transplantation that leads to the actual rejection is mediated by the adaptive immune pathway via T and B lymphocytes. And there are three principal signals that are involved: through the antigen-specific T B cell receptors, through the cytokines, which tend to activate and promote auto and paracrine signaling, such as those that involve interleukins, and finally the co-stimulation through various pathways, and most typical ones would be the CD20, CD40, and the latter much more relevant. And manipulating co-stimulative signals has shown in studies to alter T cell responses and prolong the graft's survival in solid organ transplantation. And therefore, the whole idea of co-stimulation appears to be a exciting and promising approach in controlling lymphocyte-mediated responses, and therefore improving the outcomes of antibody-mediated rejection in xenotransplantation. What about the issue of accommodation? Well, recipient accommodation is purely a condition where a transplanted organ or tissue appears to somehow resist the immune-mediated injury and eventual loss of function. And there's ongoing debate on how this actually develops, and it's really quite a long and complicated. Options are there beyond my neurons can cope with as a simple plumber. And there have been numerous past observations from the renal transplant, particularly with ABO incompatibility, where there have been such good results that this offers a promise for potentially broader application to other solid organs as well. And in terms of the last bit about the coagulation issues, we know that the involvement of natural killer cells beyond their normal function as cytotoxic effector cells is that they can initiate and regulate the adaptive immune response, and therefore can subsequently influence rejection or tolerance in solid organ transplants. And we know that natural killer cells, human natural killer cells, are recruited against porcine tissues when you perfuse porcine organs with human blood in ex situ models. So the strategy, therefore, includes blocking the molecular events that lead to the recruitment, and therefore you try and prevent the chemotaxis, the adhesion, and cellular transmigration. Two is that the expression of human major histocompatibility class 1 molecules on the porcine endothelial cells, which inhibit NK cells, are also affected. And then to try and eliminate and block the porcine ligands, which are responsible for actually upregulating or activating the human natural killer cells. So now this is all about sort of cellular nuclear transfer and cloning, and Doctors Kanga and Kaul can probably talk about this a lot more than I can, and I'm not sure what Mandeep was going to really talk about here. But just to go back to that issue about anticoagulation, is that one of the important concerns, or where we can actually do some therapy, is involving human thrombomodulin. And this is the expression of human thrombomodulin in a cloned transgenic pig. Now, we know that cardiac xenografts, porcine xenografts, show reduced survival in the absence of transgenic human thrombomodulin. And thrombomodulin has important anticoagulant and anti-inflammatory roles in the protein C pathway, and therefore numerous studies have subsequently reinforced this by showing strong anticoagulant effects of thrombomodulin in xenotransplantation, and therefore a very useful area to manipulate to try and again improve outcomes, particularly in the early phase. The worry has, of course, been also of the transmission of xenoic pathogens. Unknown risk. We just know some of these viruses that can infect us potentially, and later on in terms of zoonosis. And where do we go? How do we monitor this? How would we, in the context of a program, clinical program, look out for it, and how to treat this? I was just looking at some of those important porcine endogenous retroviruses, which of course has been another one of the risk factors that have put xenotransplantation on the back foot, is those really, Jakob-Creutzfeldt disease, or mad cow disease, as you call it in the UK, and a few other that are labeled there. Now, this is an exciting topic that's come about in the last decade, really, the whole concept of CRISPR-Cas9 therapy, in trying to get rid of now very easily all those unwanted so-called junk DNA that I mentioned earlier. And CRISPR is this sort of technology. It stands for Clustered Regulatory Interspace Short Palindromic Repeats, essentially a collection of DNA sequences in the genomes of prokaryotic organisms, like bacteria, and they are derived from the DNA fragments of bacteriophages that have infected that prokaryote, as I described earlier on. And Cas9 is a CRISPR-associated protein 9, is purely an enzyme that uses the CRISPR sequence as a guide to recognize, allowing, therefore, cleavage of those specific strands of DNA that are complementary to that junk sequence. And so it means that whether ex situ or in vivo, you can now, through those techniques, get rid of the unwanted bits of DNA that we've been frightened about for so long. And it has led to, as you know, quite a lot of work, including in humans, as that test that was done clinically to try and prevent HIV occurring in the mother, I think, of a Thai woman not so many years ago. Long-term survival, the pig to primate cardiac xenotransplants. As you know, there's an ongoing study of porcine xenograft heart transplants into primate, with Hanover sort of leading some of that work in Germany. So these knockout pigs express a human complement regulatory protein CD46, as well as a thrombomodulin. And the median survival, as you can see, is now gone to very significant levels in 5 consecutive recipients, which is adding enormous value to what was there until only just a few years back. And various other ways of modulating the CD40 can also increase the outcomes positively in terms of now xenotransplantation in man using the porcine model. So coming towards the end, what is the promise of xenotransplantation? And I've just put in an old quote from George Orwell, and we are beginning to have this, and whether we'll all have to have at some stage in our lives a named and a pig that is, that you're twinned with somewhere in case you need tissues or organs from them. And no doubt somebody will start that industry at some point. And like your price of your house, the price of therapy and the next technology coming around is a bit of a chase. But nevertheless, I do think that we're making some significant inroads into xenotransplantation. And I think the expected studies from the pig to primate heart transplants is going to, the final when that comes out, will be really interesting and may well be a very important benchmark as to what happens clinically. I can tell you that in 2017, I was in China visiting there, and I was taken to a xenotransplant colony, these small black xenotransplant pigs, and they had already then done 3 pancreatic islet cell transplants into 3 patients who were very, very end-stage diabetics. 2 of them had then came off insulin altogether, and the last one was onto very little insulin therapy. So there is promise. And now how this happens ultimately and whether we're going to end up with just xenotransplantation, I expect we'll end up with a combination of all these various therapies that were listed earlier on, including hybrid therapies that include some regeneration of tissue, perhaps xenotransplant with some mechanical hybrid in to try and help our increasing workload and number of patients with end-stage heart failure. Thank you very much. Any questions, queries? And I would ask kindly for Doctors Kaur and Kanga to be there to answer any complicated immunological question.
Kumud, it was a nice presentation with your comments. I think there were 1 or 2 publications I have seen in JSHLT for pig to baboon.
Yes.
They could manage to make them survive for a few months using this knockout galacto transplant.
That was some of that data. Yeah, that's some of that data there.
So pig to baboon possibly, I mean, but still the lifespan is short and they have to battle the coagulation issues also, considering that.
Yeah, yes. So yes, absolutely. And I think that seems to be better with this availability of human thrombomodulin genetically inserted into the porcine
So Michael,
model.
What is the medical legal status? Suppose internationally, there was one example from India. It was a pretty long back, 30 years back. There was a well-known surgeon, cardiac surgeon. He attempted it.
Yes, no, 1997, I mentioned that earlier on. Dr. Barua and a Chinese Hong Kong colleague who did the heart-lung transplant in Assam. And of course, the patient died a week later and he was arrested and jailed. But the point is that it was done and the recipient survived to a week. Now, that's an important milestone, given that the earlier ones were done, as you know, 3-4 decades ago, and sorry, before that. And so is this going to die? I don't think so. I mean, unless the other ways of trying to capture donors, increasing donor pools, become so positive that we don't need to look into xenotransplantation, I don't think so. And don't forget our colleagues across the diaphragm are very much further in that progress. So I see xenotransplantation being always there. And of course, when it comes to clinical arena, it's different. Now, I noticed Jayan is there. Is that correct? Did I see him? Yes, Jayan. Now, of course, in the old days, as I joined Papworth, they were coming to the end of the initial very rigorous, I think, interest and experimental in xenotransplantation. What is your feeling, Jayan?
I'm more of the Norman Shumway mold, I must say, but I was exposed to xenotransplantation because I was in Papua's when it was, when people were working on it. And it left me with a very bad taste in my mouth because I think it was overhyped. They were nowhere near where they, so I was actually signed up to start doing trials within a year. This was back in 97 because I'd have had to take care of the patients. So we had protocols, we were signed up as co-investigators and all this stuff. So it had reached that point. We were told, within a year this is going to happen. It's now, what, 25 years or 24 years since that happened. And actually looking back, they were absolutely nowhere near being able to do it. They were completely out. They didn't have a clue what they were doing, I think. And these were the leaders. Now, whether it was done with the idea of selling the company on, which is what happened, and one of the big pharma companies bought it out, and very quickly realized that they couldn't come to market anytime soon. Yeah. And of course, after that, xenotransplant in the UK died because of the anti-animal experiment thing. So
section, yes, which is, as you know, this is another issue that Ravi, your question brings. I mean, one thing reassuring from the Papua example is that Papua is never going to move to Addenbrooke's. It's been going on for 40 years. It's actually happened. So you never know about xenotransplantation.
So 4 years ago, I heard a talk from Chris McGregor.
Yes.
Who of course has been doing a lot of the work at the Mayo, and he said in late 2017 that within a year the human trials were actually going to start, and there was no doubt that it was going to start. I haven't heard of what's happened
since. No, I read his paper, but the problem is going back to Ravi's initial question. It's really important because in a lot of countries, xenotransplantation just will not be permitted for a very long time. DCD was much easier to do than xenotransplant is ever going to be. And I believe in India, it is going to be exceedingly difficult. My understanding is that there's no way it'll be allowed to do. And I don't think there are any xenocolonies in India.
I don't think it'll be a problem from the legal point of view in countries like the UK and the US.
Yeah.
And actually, to be perfectly honest, I think at some point it will happen. Whether you still will need whether you can lower the amount of immune suppressive therapy to the point where it becomes worthwhile is really the answer, isn't it? I mean, it's really what we're asking. And I, like you, think it'll be as the pumps get better, as the other technologies get better, which is going to be the one that saves. I mean, I hope it works. If Xeno works, it'll be really good. Yeah. But it's been going on a long time, and we haven't progressed anywhere near as fast as they told us they were progressing. Yeah. That is certainly true.
So, I mean, the question is, let's say 67, Christian Barnard did the first allograft from unrelated human being. So, in that molecular scale, where do you think xenotransplant stands? So, considering all these, we have all these molecules, these people are trying to overcome the barrier. Do you think it will reach 20%, 30%? Of the molecular challenge of making long-term graft longevity? Is it possible? Or is it somewhere nearby? I doubt that.
Somebody else should answer that who's into looking at the future. Bala, maybe your opinion would be useful here. Bala, can you hear me?
Bala.
I can see you there. What do you think to that question of Ravi's?
Molecular
I didn't hear the question.
Now, molecular is, Christian Barnard to development of cyclosporin and other drugs, they could, at least allograft, you could have at least overcome the challenges for long-term graft longevity. But what about xenotransplant? Is there somewhere nearby, you have heard this talk, co-stimulatory blockade, and you have the galactotransferase knockout. So is it reaching somewhere, or we are just, on the 10% mark where hardly made a difference in terms?
Bala, you have an opinion on that?
I'm sorry, I just joined.
Okay, all right, not to worry. Well, what's your?
I talk the next one?
Yes, it is. But what's your hope for xenotransplantation? What do you think?
It is the future, and as some cynics said, it'll always remain the future.
All right, okay. We will leave it with Norman Shumway's nice quote. If there are no other questions, are there any? We've got a couple of minutes left.
In my opinion, if I can say, I was just thinking with all the newer drugs coming in and the aspects of 3D printing and organs in the lab, probably the xenotransplantation might not take off that much, and that That's the reason that if we can manage the grafts otherwise very well, and we can handle, donor scarcity, probably the xenotransplantation, it's because of that it's not picking up that much, because focus is not on, not many people are focusing on xenotransplantation as many as we have for other immunomodulatory and adaptive immunotherapy stuff. So that's the reason somewhere the imbalance. So it's going to be a little hard and it might take much longer.
It will be, and that's why I think so much commercial interest is there. And because it's limited, because of the short amount of money available for clinical and basic translational research, is not going to go to xenotransplantation, knowing that in majority of countries there's going to be such a regulatory hurdle. So we will end there and then ask the chairs to please introduce Bala for the final talk of this session.
So the next talk is on artificial organs and cell-based alternatives. The chairpersons are Dr. Praveen Verma, Dr. Keval Krishnan. Dr. Praveen Verma is a chief cardiac surgeon of Amrita and worked as a senior clinical fellow in Brigham and Women's Hospital, Harvard Medical School for 2 years, and co-authored close to 50 publications in various journals. Dr. K.R. Balakrishnan is the director of Division of Thoracic Organization Transplant, MGM Chennai. And the speaker is Dr. K.R. Balakrishnan. And over to the chairpersons.
Sorry, could the chairs just have a mention of Bala, please?
Is Dr. Keval Krishnan here or?
Yes, I just saw him now.
Yeah, I'm here.
Yeah, Keval. Yeah, can you introduce Dr. Bala? He doesn't require any introduction as such. Yeah. So, but officially, I think we should introduce Dr. K.R. Balakrishnan. Keval, can you do that?
Yeah, Dr. Balakrishnan has been one of the pillars in this country for heart transplant, ventricular assist devices, and lung transplant, and he's probably heading most of the program which is being happening in this country, and I think it's enough for him to say, because he's one of the pioneers in this country for the program, this heart lung transplant program.
Yes, Dr. Balakrishnan, can you start your talk?
Can you see my slides?
Yeah. Yes.
Yeah.
All right. Okay. At the outset, thank you very much for this great honor to be asked to present. And I must apologize. I'm in Cairo in the Museum of Ancient History, and I'm sitting in a small cafe trying to present this, because I didn't want to miss this opportunity. And so if there are disturbances, my apologies. I've been asked to speak on artificial organs and cell therapy. Using my prerogative as a speaker, I kind of, it's not easy to speak on the entire gamut of artificial organs and cell therapy. So I restricted myself to artificial heart support, essentially LVADs, to make some sense, because that's one area where I've done some work. All of you are familiar with the continuous flow LVADs, which are currently being used. And we are also aware of the current status of heart transplant. We have published both the adult and pediatric transplant outcomes. So when we compared our transplant outcomes with VADs, at the end of 18 months, the outcomes were pretty much comparable. But when you extend it to beyond 5 to 6 years, transplants are clearly ahead, and the VAD outcomes, at least the early generation that we've been using for the last 8-9 years, have not been great as compared to transplants. So that's still the gold standard, at least in this country. And when we did a hazard ratio of LVAD usage, 1.68, so the possibility of dying with an LVAD at the end of 5 years is much higher than with the transplant. And when you plot a hazard estimate for a transplant, after the initial risk, it slowly comes down and pretty much static after the first year for the next several years, as compared to a VAD, which peaks first at the end of 1.5 years, and again at the end of 4 years because of other complications. So, and this is, even if you look at the international outcomes of HeartMate 3, the results are still not as good as LVAD. So there are important adverse events which need to be addressed for LVADs to become more widely accepted. And I divide them into 4 major categories: strokes, hypertension and aortic incompetence, right ventricular failure, and driveline infections. So I looked at each of them separately. Stroke. So working in collaboration with the Department of Engineering Design in IIT Madras, we modeled the blood flow in the aortic arch and aortic valve to answer some fundamental questions. Are there fluid flow explanations for stroke seen in LVADs? And why is there a difference between, at that time, between HeartMate 2 and HVAD and between, say, HeartMate 3 and HVAD? Are there scientific reasons? Because a lot of information in the literature is also industry driven. So people who put in the Abbott series of VADs have not used the other one and vice versa. So we looked at it very scientifically. And one of the major differences between the HeartMate 2 and 3 and versus HVAD was in the diameter of the outflow graft, 10 millimeter versus 14 millimeters. So we looked at whether the size of the outflow graft and the angle at which it's attached to the aorta matters. And we modeled the opening and closing of the aortic valve with the fluid flow interaction. And a normal pulsatile flow is parabolic, beautifully perfusing all the vessels. And when we looked at a 14 millimeter graft, it's got a very broad jet. So regardless of how and where it's connected to the ascending aorta and at what angle, it seems to perfuse all the neck vessels pretty uniformly, as compared to a 10 millimeter graft, which got a sharper jet effect. And those of you who speak Hindi, it's like a pichkari that we use in a holi. So it's got a much narrower jet effect. As a consequence, if the angle is not correct, the neck vessels, especially the innominate artery, can be hyperperfused significantly. And then when we looked at the flow pattern, a normal pulsatile flow is beautifully streamlined and regular. And even if the flow were to be continuous, but were to originate at the root of the aortic valve from the ventricle, the flow is pretty much uniform. As compared, and the flow is helical in nature. If you look at it, there is a torsion in the way the flow. And then you compare that with the 10 millimeter graft. There are so many eddies, and these eddies are much less if you have a larger diameter graft. And if you do a cross section of the aorta, these are called Dean's vortices. In a normal aortic flow, pulsatile flow, it's a very uniform and streamlined flow as compared to the disturbed flow that you see in a VAD. And most importantly, when we did what is called particle velocimetry, where you can introduce particles and look at the degree of stasis, compared to a normal pulsatile flow where there's virtually no stasis, and a 14 millimeter graft, there's more stasis, but significantly higher if it's a 10 millimeter graft. So the stasis in the aortic arch is significantly higher in smaller diameter grafts. So from this, it would seem that strokes have a fundamental fluid flow mechanism, and you should, perhaps the right-sided strokes should predominate. And apparently this does happen. There have been several publications looking at the asymmetric pattern of cerebrovascular lesions in patients after LVAD therapy, and including an aortic cannulation in children. So the next is we looked at the effect of hypertension and aortic incompetence cerebral blood flow. As we know that hypertension has an important effect on long-term development of aortic incompetence. There have been several studies, and the mechanisms given have been that over a time there is a dilatation of the aortic aneurysm leading to AI. And we looked at, we modeled the aortic valve function in LVADs to look at mechanisms of aortic incompetence. We had originally done a dynamic analysis of the aortic valve using a finite element model and published it in the Annals of Thoracic Surgery. And this actually paper has had close to now 250 citations. This is one of the most widely quoted papers in aortic valve literature. And I've done this work with the Department of Engineering Design in IIT Madras. And we had shown that aortic root is dynamic, and as you increase the pressure, the aortic root dilates. That's one of the reasons why across animal kingdom, whether it's a cheetah or a leopard chasing a deer, or a pregnant woman where the cardiac output increases 5 times, you don't have gradients across a normal aortic valve because the root itself distends, as opposed to prosthetic valves where the root is rigid. And so we also looked at the fluid structure interaction of the aortic valve, the physiology of opening and closing. And we modeled a closed aortic route in a continuous flow LVAD where the aortic valve doesn't open. And it's a slow, because of this transpiration, the video is slow. But as you can see, as the pressure increases, there's a separation of the leaflets and the commissures at the center. And the same thing happens in this image. So there is a central leak as a consequence of aortic root distension when there's a constant high pressure in the aortic root as compared to systolic and diastolic pressures in the normal pulsatile flow, which is one of the major mechanisms of aortic incompetence. And in this, leaflet geometry changes, as you can see, as the pressure increases, the leaflets tend to get separated and there is a central leak. So there is a physiological basis for why aortic leak is more likely to happen in continuous flow VADs without a pulse. And we found an interesting correlation between the impact of aortic incompetence and cerebral blood flow. If you look at the upper picture, this is a patient with no aortic incompetence. There's a column of blood, which is about 4 to 5 centimeters, which is supporting this jet from the outflow graft. And when you have aortic incompetence, that column becomes shorter. And as a consequence, the direction of the jet changes and the innominate artery gets hyperperfused. So there's a significant drop in cerebral perfusion with the onset of aortic incompetence. So the conclusions from the study was hyperperfusion of the innominate artery is possible, especially with smaller diameter grafts. And aortic incompetence has an adverse effect on cerebral blood flow. And the degree of drop in cerebral blood flow in aortic incompetence is out of proportion to the degree of leak. And this was published in the American Society of Artificial Internal Organs, I think a couple of years ago. Then the next question was, why do you get hypertension in continuous flow LVADs? Do humans need a pulse? Why does the blood pressure go up in LVADs? We have been taught that this is a neurohumoral factor at play. But we wanted to know whether, sorry. It's connected? I don't know. It's okay. So when we model the
virtual hybrid meeting,
yeah, when we model the blood pressure comparing with pulsatile flow versus continuous flow, we're surprised to find that there's a significant difference for same degree of 5 liters flow. If you have a pulsatile flow, the mean pressure is almost 7 to 8 millimeters mercury less than if there's no pulse. And to a continuous flow, as you impart more and more pulsatility, the blood pressure comes down. So pulsatile flow seems to have a beneficial effect on blood pressure as compared to a non-pulsatile flow. We also looked at the circle of Willis and blood flow in the circle of Willis. All of us are familiar with the circle of Willis, but I didn't know that it is complete only in 30% of patients. And the commonest abnormality is a hypoplasia or absence of the posterior communicating artery. And it's the commonest variant, and it's been documented in several studies, both MRI and autopsy, including from India, as a matter of fact, in Calcutta and Brazil. And it's well known in both neurosurgical literature and others that unilateral absence of the posterior communicating artery in isolation or a common carotid artery hyperperfusion in isolation has no effect. But if the two, if the common carotid is blocked, but the posterior communicating is present, the borderline infarcts are much less. So we model the flow in the right middle cerebral artery, and the normal flow is this, followed by absence of posterior communicating artery. It makes no difference. When you have an absence of flow in the carotid artery, there is a drop in pressure and flow, but not very significantly. But when both are there, that means there's hyperperfusion or absence of flow in the ipsilateral carotid artery with absence of the posterior communicating on the same side. There is a very profound drop in pressure and flow. And so this is, two factors need to be present for this phenomenon to happen. This is after the, similar to the two-hit hypothesis of described by Knudsen, who won a Lasker Prize for this, for retinoblastoma, where you have a predisposing genetic factor and acquire second mutation. So we found that if the posterior communicating artery is absent or there is a carotid hyperperfusion, in isolation, there is no damage to the brain's viability. But if the two are together, that is ipsilateral carotid hyperperfusion with absent PCA can cause a stroke. So clearly, patient-specific factors can influence strokes. So this was first presented as a podium presentation in Orlando, and we published in the Journal of Heart Transplant. So what is the reason for the high pressure in continuous flow VATs? So we did a comparison of blood pressure in a pulsatile flow and an LVAT flow with the imposed pulsatility using a wave propagation model. So we did the Fourier transformation of flow and pressure. And in a normal young individual or in young animals, the effect of wave reflection is such that the systolic blood pressure comes down and the diastolic pressure goes up. So the difference between the mean pressure and the systolic peak pressure is very little. And as you age, the difference widens. And interestingly, I'm in Egypt, so I thought I'll include this slide. This was first described by Joseph Fourier to describe thermal hemodynamics and thermodynamics, but is widely used in wave propagation. Interestingly, he was a general in the army of Napoleon, was stationed in Egypt when Napoleon conquered Egypt. And in his spare time, he described Fourier transformation. Apart from doing translation of Egyptian hieroglyphics, which gives us great insight into ancient Egyptian history. And the first person to demonstrate wave reflection, again, has an Indian connection, was a cardiologist called Sheikh Dean Muhammad. His father was a barber in Allahabad and Bihar who specialized in what is called champa in India. It's the forerunner of shampoo. And one of the East India Company army officers became friendly with him and took him to England, where he started doing this in all the baths in England and became a hairdresser to the King of England. And his son became a cardiologist, interestingly. And he was the first person in the world to describe wave reflection in human beings 150 years ago. I just thought it's an interesting anecdote to share. The types of impedance are of some interest. Input impedance is what you might get at the entrance of VAD into the aorta, or what an aortic stenosis will cause to the left ventricle. Longitudinal impedance is what happens to the length of a vessel, and so on and so forth. But when we looked at the effect of pulsatility on aortic impedance, we found very clearly that a non-pulsatile flow has the highest impedance as compared to fully pulsatile flow. So apart from neurohumoral factors, the physics of pulsatile blood flow seems to contribute to the lower blood pressure in a pulsatile flow as compared to continuous flow. So imparting pulsatility may have a beneficial effect in the lowering of blood pressure, and that there are patient-specific anatomical factors in the aortic arch branching pattern which can have an effect on stroke. This was published, presented, and then published in GHLP. The third is RV dysfunction, which is again an important factor contributing to poor outcomes. So working in collaboration with the Department of Engineering Design, IIT Madras, we created a full electrical model of the human cardiovascular system and generated virtual pressure volume loops and modeled left ventricular, right ventricular, and biventricular failure. As you can see, this is a normal pressure volume loop in blue. When you have both RV and LV dysfunction is red, and when you have medical therapy, which is vasodilatation, the pressure volume loop shifts to the left, as you would expect, leading to higher stroke volume, higher cardiac output at a lower filling pressure. But this comes at a price. The aortic pressure is lower, the LA pressure is lower, so the patient is symptomatically better. But interestingly, the right atrial pressure goes up. So at least for me, it was new that not just in LVADs, but even in normal medical therapy, if the cardiac output improves as a consequence of lowering the arterial elastance and causing vasodilatation, the increase in cardiac output has to come to the right heart, and as a consequence, the right atrial pressure goes up. In a patient with normal right ventricular function, this may be of no consequence, but in patients with RV dysfunction, this has profound significance. So when we plotted the difference between mean aortic pressure and mean RA pressure compared to a normal in LV and RV dysfunction, the difference is on this hypothetical model around 60 odd. Whereas if you have LV and RV dysfunction with vasodilatation, the perfusion organs drops drastically. And that's what we see clinically. When you have biventricular dysfunction in a vasodilated patient, the end organs suffer significantly with end organ dysfunction. So what happens if instead of, or along with vasodilatation, if you were to add an intra-aortic balloon pump, because intra-aortic balloon pump has been shown to be of benefit in heart failure And when we modeled that, we found that the aortic pressure increases. And even the difference between the increase in right atrial pressure with balloon dilatation, with intra-aortic balloon pump versus just vasodilatation was minimal. So the cardiac output is significantly higher. So this is the mechanism by which IABP seems to benefit patients in biventricular dysfunction by improving the perfusion pressure of the organs by augmenting the aortic mean pressure, while the RA pressure is not significantly more elevated as compared to vasodilatation alone. So IABP has physiological benefits in patients awaiting LVAD insertion and in transplant patients awaiting transplant, especially if there's RV dysfunction. With this knowledge, can we design pumps which are more physiological? So we are now working with an Australian company where we have designed a VAD system where a single controller can control both RVADs and LVADs with an implantable Y connector. And we got in fact, both US and Australian patent with 3 other Australian engineers. And we probably need a flatter HQ curve to impart physiological pulsatility to reduce aortic incompetence and hypertension. And pre-surgical planning for choosing the Alpha-Grad configuration based on individual arch anatomy and flow simulation might be the future. And in fact, there is already some experimental work using flange grafts of 10 millimeter grafts expanding to 14 millimeter aortic, and especially this work has been done by Chris Hayward and St. Vincent's. And we have started using virtual reality for optimizing LVAD patients, working with the IIT Madras group, and this has been published. So the video on the left shows that, especially in smaller build patients and in pediatric patients, you can implant the VAD virtually and choose the ideal size for VAD implant so that there is no compromise on impinging on septum and so on and so forth, and making sure the chest closure is possible. So new technology in the horizon, I think we will see in the next few years. Already Bluetooth LA pressure monitoring for up to 6 months is possible, maybe with biofeedback, so that some kind of a flange stalling mechanism is possible with VADs. These are not yet commercially available, will happen soon. Continuous pressure, aortic pressure monitoring for better blood pressure control. We are working, as I said, with a group in Sydney, where based on the HQ curve and other data, we are in a position to predict the aortic flow. If you know either the LA pressure or the aortic pressure, you can predict the other one. So if you're able to predict assess the LA pressure by echocardiogram, for instance, you might be able to predict the aortic blood pressure without having to invasively monitor it or measure it. We need better advances in anticoagulation, and eliminating dry gland sepsis is perhaps most likely to happen the first with more transcutaneous energy transfer systems. So in conclusion, designing artificial organs makes us realize the majesty and wonder of human evolution and the inherent beauty of the human body. Fundamental studies are needed to better understand how our body functions. This is work in progress and likely to take several centuries, in my opinion. The work is humbling, almost spiritual, makes us realize the importance of prevention. Thank you very much.
Thank you very much for that really wonderful presentation, and a lot of it your own stable, which is wonderful to see such good work coming out of India, and very translational work, not least in what's coming in the future in terms of devices that you're helping to produce that I hope will particularly help in India in relation to cost and how it may actually help both ventricles with that single controller. I've got some questions, but I'd rather leave it to the chairs and the floor in case there are some questions already waiting to be answered. Chairs, do you want to tackle the questions if anybody has posed some questions on the screen?
I don't have any, I can't see any in the chat so far, any question.
I have one.
Yeah, Dr. Ravi Kumar, yeah.
Dr. Bala, good talk as physics. But what do you think is the fundamental solution for RV dysfunction with biventricular dysfunction? And you have no other, heart transplant is not an option. So again, going back to the HM6.
More reliable biventricular support already compared to 2 or 3 years ago, we are using a lot more and we are much more liberal with the use of perioperative biventricular support, sometimes for as long as 2 months. Not only does it increase the acceptance of patients into a VAD program, it also makes recovery quicker rather than being stuck on inotropes. And as I said, this modeling studies of biventricular dysfunction shows that if you're expecting any kind of increase in cardiac output, it has to come at the expense of increased preload to the right atrium or right side. And so whenever you increase flow, the right ventricular dysfunction gets unmasked. More liberal use of RVADs will happen. And one of the reasons why there's been not more widespread utilization of BioVac technology has been the fact that you need 2 controllers, 2 pumps, 2 sets of batteries. Is very cumbersome. But if you were to simplify it in such a manner that you can put it in, and if you no longer require RVAD support, you could either run it at very low flows or switch it off. Maybe that might make VAD safer from the point of view of RV dysfunction.
You mean like 2 centrifugal pumps and one is switchable off? For example, HM6 and one HM is...
Whatever. Yeah, that's the idea. As I said, there's a big gap between concepts, ideas, and long-term performance, but at least it's one thing that we are pursuing.
Or you think future the syncardia total artificial heart would? I mean,
total artificial heart might have its role, but I'm not sure it's going to totally supplant biventricular to a conventional VAD therapy, because to excise a heart, especially in redos, multiple redos, will have surgical challenges.
Dr. Balakrishnan, I'm Dr. Verma here. Yeah. So I have one question. Has HeartMate 3 made any difference in the practice compared to HeartMate 2?
HeartMate 3, I find, is much more forgiving of anticoagulation. We have run patients on HeartMate 3 for up to 2 months without anticoagulation when they've had a GI bleed or when they've had other issues without any kind of issue with LVAD thrombosis. I think it's the most forgiving of VADs that, at least in my limited, maybe Jayan and all that might have much more experience with. HeartMate 3 seems to be more friendly towards easier anticoagulation policies.
Yeah, if I can add to that, Bala, I would, we've had the same experience having moved from HVAD to the HeartMate 3. It is much easier. You don't have to worry about the anticoagulation quite as much. And actually, a 1 year survival, with the same surgeons doing it, has actually gone up. So now at 1 year, we'll find the outcome from a heart transplant and the HeartMate 3 is about the same. But I entirely agree with you. At 5 years, at the moment, the heart transplant is still going to be much, much better. By the way, that was a really nice talk. Thank you.
Dr. Balakrishnan, I'm Dr. Verma again. So it was very interesting to see that the graft and the flow through the innominate artery and all those things. So my question to you is that, is there any way by surgery we can adjust the position of the graft so that there is a much more uniform distribution through the cerebral vessels?
Yeah, sure. That's what I meant. Except for emergency VADs, which are not common, most VADs give you some time. So in principle, it's possible to image the arch vessels and do a flow study and do a surgical planning. At this point in time, still a research modality, because I have the luxury of working with a big research group I have access to. So it eventually needs to be commercialized in such a way that the turnaround time is short, and it'll happen. It's a matter of committing the resources to develop an app so that from a CT scan, somebody is able to do a flow study. And so patient-specific modeling will happen in our lifetime, perhaps sooner than we think.
Dr. Keval, do you have any questions?
So do you think with this, suppose this HeartMate 3, still there is some chances of thrombosis? Can we, if we bioline the impeller, is it possible to reduce the incidence of thrombosis to make it more biocompatible?
All these are interesting questions, but the real world of device development is such that any change you make to any of this, you have to go back to the drawing board and start from scratch. So the economics of new innovation and existing products is so high That's one of the reasons why, actually, when we started designing this pump, we realized a lot of technology is pretty old and fossilized essentially because of the logistics of getting through regulatory issues.
Dr. Bala.
Yes, that's actually so, that is so crucial in device development, and hence the increasing, I think, search to try and increase the modularity of these devices, because you then only can change individual components without having to redo the whole thing, and hence why we.
Would like to continue the call? 1 minute, yeah, good.
Yeah. Hello.
Yeah, hello.
Yeah.
I'm not able to hear Kumud.
Yeah, can you do the comment again, Kumud? Is it Dr. Kumud?
I'm sorry, no, I don't know what you heard, but I've been having power outages. The comment was really just to reiterate what Bala has said about development and why technology is to be so old. But there is lots on the table. And in fact, we've been hearing about transcutaneous devices, tether-free VADs for now a number of years. And it's always been like xenotransplant in the sense, oh, next year we'll have it. We've had the Lionheart that died very shortly. And I suspect it's still going to be another 2 to 5 years before we really have for a quality of life issues, a tether-free alternative that's going to be,
I think we have lost him. I'm not able to hear him.
Dr. Bala, Dr. Verma here again. So can you speak a few words on the cell-based alternatives? That's also part of the, what is the current situation now? And what do you think is the future?
I am not sure what the future is for cell-based therapy for heart failure at this point in time. There have been, there have been several studies looking at use of cell-based. About 15 years ago, there was a lot of enthusiasm that patches and stuff will make a difference. But I have not come across anything convincing for end-stage heart failure. There have been some studies looking at myocardial infarctions where you inject cells and show that at this point in time, the most promising results of cell-based therapy seem to be in peripheral vascular disease. They've also been looking at lung scaffolds to grow pneumocytes, but as I said, nothing in the immediate clinical horizon which is going to make a big impact on outcomes, as I see it.
Now, I would concur with that, unless there's some urgent questions. I think we've come to the end of the session. I just want to thank everybody else for, I think, 2 great sessions yesterday and today, and the participation. I'm going to hand back to the chairs to probably Jose to wind up.
Yeah, again, I would like to apologize because I'm presenting it from a cafe, and I'm not even sure how good the transmission was.
No, you're very good, and it's wonderful that you can do it from a cafe. It's a new way of working, I think.
And thank you very much for the wonderful session. And I must admit that the entire credit goes to Dr. Kumud Dittal. And we kind of put all this together in the last 2.5 weeks. We had a very short time. Isot was not very kind to us, letting us knowing that we have to do the scientific sessions. And I think, as we are aware, things were not very well organized because of the online issues. In spite of that, Kumud could get so many faculty, high standard faculty, to kind of speak and share their experiences on their respective field. And I'm thankful to each one of you, especially to the faculty who were presenting from odd places like Bala from Cairo in a cafeteria, which is as exciting as the contents of his speech. And thank everybody. And on behalf of the Society for Heart Failure and Transplantation, I thank our president, Dr. Nanda Kumar, Secretary Jabir, as well as Dr. Manoj Durairaj, who is a scientific committee organizer, Punan. And a special thanks once again to Dr. Kumud. And whenever we have a problem with the scientific contents, we always depend upon this gentleman who is not only good at his work, but also good in the speech as well as a great organizer. And I thank you once again. Before I conclude the session, if you would like to say a few words, Kumud, you are most welcome. And on behalf of the society, let me thank each one of you and say bye until we meet again.
Well, thank you for the kind words, but I think there are a lot of people involved in this organization. I think the really thing to say is that this sort of dialogue is crucial and important. And I hope that the two sessions from yesterday and today will not only improve from yesterday's our playing field in terms of training, regulatory regulations, our own guidelines. I think standardization across the thoracic societies that are being represented here. I can see Kevil's here. And then in the future, I think India, as I see this coming exponential rise in thoracic transplantation and servicing the heart failure population, is going to create such opportunities that we need to latch on early and get into integrated ways of looking at this so we can be part of evolving this practice. And we won't be able to do that without adequate registry databases, collaboration, and good academic output from our institutes. This is not a lack of a secretary. This is not a lack of an IT officer to put in data. This is a lack of actually really decision-making and a wish to want to make it happen, because the cost of these personnel, as pointed out yesterday, even by Jayan, is very small. And so that's not the blame. I think the blame is really us getting our heads around as seniors to make it happen. Do we want it to happen? Yes, we do. And I hope we'll see this unfolding with other meetings in the coming year. I'd like to conclude this and thanks everybody, and I wish you all a very happy Saturday evening.
Thank you. Thank you very much.
Once again, thanking everyone for today's session. Wishing everyone a pleasant evening. Thank you.
Recording stopped.